Welcome, everybody. Good morning. Thanks for joining us. I'm Miguel Eckstein from Psychological and Brain Sciences.
And I'm William Wang from Computer Science. Together with Miguel, we co-direct UCSB's Mellencamp initiative in Mind and Machine Intelligence. So this is a cross-disciplinary effort that we bring together UCSB's academics to understand the capabilities of human mind and also artificial intelligence. So we were very interested in understanding the design of AI that is centered around fruitful interactions with humans. And today's event and the initiative is made possible by the generous gift of Duncan and Suzanne Mellenchamp.
Our 2021 Virtual Annual Summit focuses on the timely topic of AI and health. The path ahead for the increasing role of AI in health is exciting. AI can tap into information that a doctor's mind might not have access to and can improve a physician's ability to detect and treat disease. Yet the challenges ahead are equally great. In many applications, from machine vision to natural language processing, AI has shown to be brittle to small perturbations of the data and simply is not as robust as humans when faced with unusual circumstances. In addition, there are challenges on how we can best merge AI and doctors in clinical practice to ensure, on one hand, that doctors do not ignore altogether AI recommendations, and on the other hand, they just do not blindly follow the AI recommendations. And finally, this year has made us think deeply about how we can capitalize on AI to help us navigate the incredible challenges of a global pandemic. These are some of the questions we will be addressing over the next few days.
Our annual summit will consist of 3 days, and each day will have a 3-hour event covering the topics of AI and doctors. So that's the first day, and patients. And second day, we'll discuss AI radiology and decisions. And finally, Thursday, we'll talk about AI and COVID-19. So each day, there will be a 15-minute keynote section, and followed by the 3 20-minute guest lectures. We'll have questions after each talk about the talk itself, but we'll also have a moderated discussion at the end of each day with participations of all the speakers and the audience. To the audience, please use the Q&A function in the Zoom webinar to ask your questions to a speaker. The virtual summit today is co-sponsored by UCSB's Center for Responsible Machine Learning, Center for Information Technology and Society, UCSB's Institute for Collaborative Biotechnologies, and also Cottage Hospital.
Thanks, William. Okay, so I will introduce our keynote speaker for today, Ziad Obermeyer. Ziad is an associate professor and Blue Cross California Distinguished Professor of Health Policy and Management at UC Berkeley. His research and teaching focus on machine learning as a tool for improving human decision-making in health. He has received a number of awards from the National Academy of Medicine, National Institute of Health, and multiple academic societies. He both publishes in general high-impact journals like Science, also medicine journals like Nature Medicine, the New England Journal of Medicine, but also in a lot of the high-end computer science conferences. He's really bridging these two fields. He's a faculty research fellow at the National Bureau of Economic Research and continues to practice emergency medicine in underserved communities. And today, he will tell us about what AI can teach us about human intelligence. So thanks, dear, for agreeing to be our keynote speaker.
Oh, thank you so much. I'd rather be in Santa Barbara, but maybe next time. But thank you for inviting me virtually nonetheless. So I wanted to start off with kind of like an observation and a worry that I have, and that I think a lot of people have about machine learning, and that is that you look around and everything about your day-to-day life has effectively been transformed by machine learning. It's like how you drive in traffic, how you buy products or watch movies, and as we're increasingly realizing, the diagnoses that a doctor might be arriving at when you go to the ER or to your clinic are increasingly guided by these kinds of tools. Now, all of these things are deeply interesting problems. I mean, traffic is super interesting. Behavior, medicine, all these things are kind of, academic subfields in their own right. And so the fact that machine learning is helping with them is really great on some level. But it also brings up this worry that it's just predicting stuff and it's doing lots of useful things, but is it teaching us anything? Can we learn anything from these tools? And I think one of the directions that the research has gone in is trying to open up these black boxes. So they are, prediction machines. They're just correlation finding machines. And I think that, it's not an uncontroversial observation that it's proving very hard to open up these black boxes and understand the why of why is this thing predicting this other thing? In the same way, not as a technical problem, but as a deep observation about data. It's just, regression output can be very inscrutable sometimes too, even though that's not machine learning. So a lot of stuff has gone into trying to open up the black box. And today I want to give you 2 examples of a different strategy where we actually leave the black box, but use the black box to teach us about something else. So I want to just walk through 2 case studies from work that I've done with co-authors where I've actually learned something about the world from artificial intelligence, not just how to predict something, but actually something deeper about how the world works. So 2 items on the agenda today. The first one is what AI can teach us about psychology and human behavior, and specifically about how physicians, one kind of expert, makes judgments. And the second is actually a deeper truth, I think, about medicine and about physiology. So why don't I start with the behavioral science that I think I've learned from working in this area. I want to set the stage by telling you about a problem that as Miguel mentioned, I still practice emergency medicine, and a problem that all doctors in ERs, but in clinics and other places around the world face is a patient will come in with some subtle symptom like nausea or a little shortness of breath or chest pain. And one of the things on your mind all the time is this patient having a heart attack, a blockage in one of the coronary arteries supplying the heart muscle? So if you're in the ER, you're lucky because you get to do immediately some cheap tests like an electrocardiogram or some laboratory studies. And those things can help triage and they can be very suggestive, but nothing that you do in the ER is going to tell you definitively whether or not the person is having a blockage in one of their coronary arteries. For that, you need to send them somewhere else in the hospital, and you need to subject them to an expensive and often kind of risky and invasive set of tests, perhaps starting with a stress test, but ultimately the gold standard test that you need to diagnose a blockage is catheterization. It's an invasive procedure. There's a risk of stroke. It's uncomfortable. There are many downsides in addition to the financial costs. So that is a hard decision. And it's one that, physicians don't tend to make very well. There's a lot of literature that suggests that this decision goes wrong, largely because physicians seem to over-test people. We order a lot of tests that come back negative. So testing is a really good problem for machine learning. And let me explain why. When I do a test in the ER, if I send someone to this catheterization laboratory and I expose them to all of the risks and the costs of testing, if that test comes back negative, that is just a cost. That patient has received no benefit from that test. There's no blockage, and I haven't been able to deliver any treatments. So if there is a blockage and there's a positive test, that unlocks this huge benefit of treating the blockage. So, decades of clinical trials have shown that when someone shows up in the ER with chest pain and you open up a blockage in their coronary arteries, they get this huge benefit from that treatment. So the positive test allows you to target that treatment. The negative test is a waste. You've just paid all the costs and you've got none of the benefits. So the value of the test depends on its result, which means that one of the things that doctors are supposed to do before getting the test is predict the likelihood that that test is going to be positive, that the patient actually has a blockage. And if that person is above a threshold, then you do the test to confirm, and you make that judgment using all of the information that you observe about the patient. And if you're an optimal kind of econ style doctor, then you set your cost benefit threshold and you test everyone above that threshold and don't test anyone below that threshold. And it's very simple. So that's why this is a good machine learning problem, because the value of the test depends on this piece of information that you don't have when you're making the decision to allocate the test. It's the result of the test. And that's something that a machine learning algorithm could give you. So what we do is we form explicit predictions on the test outcome using very standard ML techniques applied to electronic health record data. So specifically, we look at everyone who got a test in and around that ER visit, and we predict who's going to get the treatment for that test as an observable proxy for the value of that test. And we're going to use those predictions to judge how the doctor is implicitly making predictions by revealing their predictions in the form of a testing decision. Concretely, this is one top-ranked academic hospital. We take all consecutive ER visits over a 4-year period. We take all the tested patients, we predict the outcome of testing with an ensemble model that combines a gradient boosted tree model with a lasso model. There are a lot of variables. So we take all of the information we have in the electronic health record, labs and vital signs and diagnoses and procedures, and we turn those into variables, or as the cool kids call them, features. That's what we call variables now in machine learning. And we train that algorithm on a 2/3 random sample of patients. So all of their visits are together. And all of the results that I'm going to show you are on a random sample of holdout patients that the model has never seen before. So let me start by giving you one statistic about the tested people. So if you look at the unconditional probability of getting a treatment in the tested, so this is what I'll call the yield of testing, that's about 14.5%. And if you turn that into an estimate of how much are you paying for a life year using the clinical trial estimates in the literature and the costs and all of the assumptions that this literature kind of has honed over the past few decades, you get out of that machine a cost per life year of $87,000 a year. Now that's generally considered pretty good value. Like the rule of thumb is $100,000 a year is the upper limit. So this is actually looking on average cost effective. So, you know, if you had to say, well, should we be in the business of doing these tests? Your answer would be, yeah, this is cost effective by most standards. Now let me show you this same statistic through the lens of ex-ante machine learning predictions. So this is, again, in the holdout set of tested patients. So this is everyone that doctors suspected strongly enough of having a heart attack to test them in or around that ER visit. This is largely in the 2 days, the 48 hours after the visit is like 85% of all of our tests. So doctors are suspicious. They're testing all these people. What I've done is I've taken all the tested people in our holdout and I've binned them into 10 groups. So these are deciles of predicted risk. So we're just using that prediction to bin people in the holdout set into groups of ascending risk. So low risk on the bottom at the 10th percentile, very high risk at the top. And you can see that that line is sloping up. And I actually find this kind of miraculous already. So doctors are testing all these people. We put their data through the algorithm, and we can find a large number of people that have both very low and very high yield, all within the group of people that doctors are suspicious enough to be testing. How high, how low? In the lowest bin, you've got a yield of testing of 1.6%. In the top bin, it's over 50%. So this is finding a lot of signal. And now if you critically put those numbers again back through that cost effectiveness machine, now you're getting incredibly cost ineffective tests in these bottom few deciles of predicted risk. You'd need to be willing to pay over $1 million per life year. And even in this country where we are big spenders in terms of cost per life year, we are unwilling to pay that much. Whereas in the top bin, you're getting a value of under $50,000 per life year, which even in Europe they would pay for. So this is finding a lot of heterogeneity within the set of patients that doctors have already decided to test. And I think that's a really important insight for the enterprise of identifying low value care. So we're no longer, we can now be in the business of telling doctors like, oh, you're going to do a test on this patient. This patient is going to have low yield. And we're correct in the way that you see on this graph. One thing you might wonder, so this is a great tool for eliminating these low value tests down in the bottom, like 50%. So at normal cost effectiveness thresholds of like 100,000 per year, you'd cut over half of these tests ex ante using information that you know at the time the decision is being made. what about the people at the top? So we can generate predictions for everyone in that top 10%. So generate the prediction, apply that even to the people who haven't gotten tested. And we find that actually a large number of these patients that the algorithm thinks are very, very high risk that the untested patients look very high risk and the doctors aren't testing them. So the problem is, of course, that there's a selection problem. So doctors aren't testing people randomly, not even conditionally randomly based on what the algorithm sees. The doctor can examine the patient. The doctor can talk to the patient. There are tests that the doctor does in the ER that mean that we can't just uncritically take these estimates from the tested group and assume that they hold in the untested group. And one of the things we do in the working paper version of this is show how dangerous that assumption would be. So I'm going to skip all of that, and I'm just going to tell you the way that we confirm that this algorithm is finding true signal, not just in the tested patients, but also in the untested patients. And that's by looking at what happens to the untested people that the algorithm thinks are high risk in the 30 days after their visit. So we've taken out everyone over 80 years old, everyone with a diagnosis like cancer or dementia, and everyone that the doctor has given any indication that she's suspecting a heart attack in the ER. We're honing in only on these people who have other diagnoses, like the doctor thought it was pneumonia, or the doctor just sent them home. And we're looking at the adverse event rate in these generally healthy people that the doctors are not testing for heart attack, and we're seeing what happens to them. And in those 30 days after that visit, almost 10% of these high-risk patients are having one of the following events. They come back with a heart attack, or they get treated urgently for a heart attack. They have cardiac arrest, or they need CPR for cardiac arrest, or they die. And so 9.2% of those patients go on to have one of these outcomes, and about half of this is death. If you break those out separately, you find the same thing. And then if you use the quasi-experimental playbook and try to find settings where patients are as if randomly assigned to more or less testing, in this case, based on the fact that certain triage teams test more than others in a way that's unrelated to the patient risk, you find that when high-risk patients are assigned to high testing shifts, they end up with 30% fewer of these adverse events over those 30-day periods. So not only is this real risk that the algorithm is finding, it's preventable risk. When these patients are tested more, they do better, and only the high-risk patients. When the low-risk patients are tested more, they actually do slightly worse. So the algorithm is finding real signal. And I think that that is important because it gives us a new insight into how physicians are thinking. The standard model of how physicians think is physicians test poorly because our healthcare system is set up so poorly in terms of its incentives. So imagine the physician is seeing some set of patients with some distribution of risk, and the people in the right tail are the people who should be tested, and everyone else shouldn't. So there's some break-even point. And if you go back to the idea of a kind of like the perfectly rational doctor, that doctor would find that break-even point, test everyone above that threshold, and not test anyone below that threshold. The problem is that because of malpractice, because of financial incentives to doctors and hospitals, doctors move that threshold down. They set the threshold too low. They see this whole risk distribution, but they move that threshold down and they start testing these medium to low risk patients because they're incentivized to test more. And that's what gives you this low average yield. They're dipping down into the low risk part of the distribution. And so those high risk patients that go on to need treatment are getting diluted, and we see low average yield. That's the standard moral hazard model of physician behavior. And I think that's the model that underlies most of our efforts to change the healthcare system and to affect physician behavior. Here's a different model. Misprediction. So now imagine that instead of these patients being nicely rank ordered in the physician's mind, they're still nicely rank ordered, but in reality, they're completely misranked. So now notice that no matter where you draw that threshold, you're going to get the marginal patients are going to be both high and low risk. The patients that you test are going to be a mix of high and low risk, no matter where you are in that distribution, because the patients are misranked. But notice there's also this other empirical prediction of the misprediction model that moral hazard doesn't have, which is that when your patients are misranked, you're also getting high-risk untested patients, not just low-risk tested patients. So this model, this misprediction model, actually fits the data that we observe a lot better. We see over-testing of low-risk patients, but we also see under-testing of high-risk patients. So when we look at that in the data, we can bin these triage shifts that test more or less, and we can see how they're testing. So the high triage testing shifts this is the testing rate on the y-axis and the algorithm's prediction on the x-axis. And I've just binned patients into which shift they see. Do they see high? Are they randomly assigned to higher testing shifts or lower testing shifts? And what you can see is that those lines are stacked on top of each other everywhere in the risk distribution. So the low testing shifts, they cut wasteful tests. They're doing fewer of these low risk tests, but they're also doing fewer of the high risk tests. And when we look at this pattern across the country in Medicare data, in every hospital in the country, we see the exact same thing. High testing hospitals test everyone more, low testing hospitals test everyone less. So again, more facts that support this misprediction view of physician behavior, not just moral hazard. Now, I promised you some why, some insights into human behavior. And let me try to convince you of two things. So we built another model. We used the same machine learning infrastructure, but now we're interested in a different object, not the patient's risk, but the physician's testing decision. So what can the algorithm actually tell us about the physician's testing decision? And the thing we did is we used our standard machine learning pipeline to predict risk as before, but we constrained the model to simpler and simpler functional forms and fewer variables. So I'm just going to show you, I think the most elegant form of this result is just showing you how models do when they use fewer and fewer variables than our full machine learning model. And I'm going to compare how they predict two things, the patient's risk and the doctor's testing decision. So y-axis here is R squared of a model for predicting an outcome, risk and test, and I'll show you both. And as you go further and further right on the x-axis, we're adding in more variables. So this is getting more and more complex as we go to the right, as measured by the number of variables that the model is taking in. So fact number one, when we look at how the R squared does, we see the standard machine learning thing of, it's getting better and better and better for predicting patient risk, the yield of testing, as you add more variables up until a point, and then it falls off as the model starts to overfit. So this is performance in the holdout set of a more and more complex model. It goes up and then it goes down, and the peak is at 224 variables. Now we're going to do the same thing, but instead of predicting patient risk, we're going to predict the doctor's testing decision. And what you see here is that you see that same pattern. It goes up and then it goes down, but the peak is much lower. The best predictor of the doctor's test decision only has 49 variables. And this finding is robust no matter how you specify complexity. If you use depth of a tree or any of the other machine learning regularization tricks, you find the same thing. Physicians are using a much simpler model of risk to guide their testing decisions than the algorithm would use to fully capture the patient's risk. So we interpret this as evidence that physicians are acting in a way that is boundedly rational. The test decisions that they're making look like they are the realization of a very simple risk predictor relative to what an algorithm is seeing. And we also see that in the form of individual variable weights. So this scatter plot just shows you for that simple model of physician that best predicts the physician testing decision, 49 variables, how the correlation of that variable with risk relates to the correlation of that variable with tests. So you can think of these as like the coefficients in the model. And you can see that they're lining up really, really well. So the R squared of this is 0.43. So the weight that the algorithm is assigning to a variable is very similar to the weight that a physician appears to be assigning a variable like age or sex. At the same time, there are some outliers. So chest pain, for example, very salient symptom to anyone who's been to medical school. This appears to be much more correlated with the testing decision than it is with risk. And similarly, age appears to be much more correlated with testing than risk. And so that suggests that in parallel to this boundedly rational view of physician behavior, we might also be seeing evidence of specific biases. So the way we test that, and I'm sorry to show a regression table, but I didn't see any other option, is we create new machine learning predictors, but based on these subsets of variables. So we've got a machine learning prediction that is purely based on the patient's demographics, purely based on their symptoms, purely based on their laboratory studies. And we just separate these out. So let me just show you one set of results that suggests that certain types of risk are being overweighted. So this is a simple regression to start things off of the testing decision on the risk. So you can see that, physicians are actually behaving the way we would hope they would be behaving. They're testing people more as the risk goes up. So that's just one variable. Now we're going to add in a second variable. So we still have the full predicted risk. This is the full machine learning model that we would hope the physicians are testing according to. But then we also add in another variable, which is the machine learning prediction of risk, but only using the risk information contained in symptoms. And what you can see is that the coefficient on that is not only significant, it's bigger than the coefficient on the full risk score that the algorithm is assigning. So physicians appear to be overweighting the risk information, true risk information that comes from the patient's symptoms. We can go further. We can create similar variables for demographics, for diagnoses and procedures. And we see that, in addition to that top line of the full machine learning risk score, physicians are overweighting symptoms. They're overweighting demographics, and they appear to be underweighting the risk information contained in much more complex quantitative stuff like labs and vital signs. They're also misweighting the information that comes from a patient's medications. The final thing we do is we notice that not all symptoms are alike. Some symptoms match the textbook definition of a heart attack more than others. And we define this empirically based on the ratio of the symptom in the people who were found to have heart attack versus the amount of that symptom in the general population. So this is a metric of whether the symptom is representative in terms of a representativeness heuristic. Is it representative for heart attack? Does it fit your stereotype of what a heart attack patient looks like? And we find that that is the only thing that matters for this symptom-based risk score. It is a huge weight in the physician's mind when a patient has chest pain or some other symptom that is a textbook definition of heart attack. So this suggests that in addition to our previous result on bounded rationality, physicians are also falling prey to these specific biases, stereotypes, and representativeness. So here's the summary, or how I view this set of results. Physicians are making systematic errors in risk prediction that cause them to over and under test, and that happens across the risk distribution of patients. Part of that is that they just can't process or attend to or remember these hundreds and hundreds of variables where the machine learning model has a huge advantage. And part of that is specific biases that are the incarnation in the expert judgment of physicians of these known biases and errors in the literature. Okay, so that was our first case study about what machine learning can teach us about how physicians think. Let me switch gears and try to also make the case that machine learning can tell us about more fundamental things about patients, about medicine and the causes of pain. And I'll start with a puzzle that's in the literature that some of you may be familiar with, which is that this isn't a puzzle. There are very large pain gradients in society by race. So if you look at these surveys that ask people, have you experienced severe pain in the past few days? It's very striking that non-white patients report this twice as often as white patients, and similar results and gradients by income and by education in severe pain. And I think this is already a very striking finding. Now, one explanation that is kind of everyone's first thought is, well, these people have more things that hurt. And so I'm going to be telling you about one particularly common cause of pain. It's arthritis in the knee, knee osteoarthritis. And so if you look at gradients, there are gradients along all of these same dimensions that people have found in pain. But interestingly, that doesn't seem to be the whole story. So here's the puzzle, is that we can actually adjust for the prevalence of these painful conditions. We can look at people with knee pain. We can get their x-rays, and we can look at their x-rays, and we can compare like to like. We can compare a patient who's Black, who has a knee x-ray that looks like moderate arthritis, versus a patient that's white who has the same degree of arthritis in their knee. And what this literature has found is that Black patients and lower income, lower education patients still report more pain, even when we condition on the x-ray graded severity of their arthritis. So the way the literature has kind of wrapped its head around this problem is to say, well, we've controlled for the knee. So we've conditioned on the severity of disease in the knee, and we haven't found that as our explanation for the pain. And so if the pain can't be explained by what's in their knees, maybe it's in their heads. I don't at all mean this in a pejorative way. There's a lot of very solid research that suggests that applying the same physical stimulus to someone who's under a lot of stress is more painful to the person who's under stress. Anxiety and depression can manifest as pain. There's also, given all of the pressures and kind of other considerations that are happening in someone's life in low income, low education, non-white communities, there's just like lack of bandwidth and abilities to cope. There's also the possibility that the medical system is just treating these patients differently and denying them access to therapies that can mitigate pain. So that's what the literature has kind of said on this. And notice that all of these explanations are not in the knee. They're somewhere else in the medical system or in psychology. So let me just walk through a very concrete clinical scenario. So imagine you're a doctor and your patient comes in with knee pain. You're going to send her to go get an X-ray of her knee. And if we take this literature seriously, the implication is that if that patient is Black, it's more likely to be the case that the radiologist sends you the report and says, well, knee looks okay. So that pain is not going to be reflected in the disease severity that the radiologist sees. And that's going to lead you to pursue treatments that are not about the knee. You're not going to send that patient to an orthopedic surgeon or a physical therapist. You're going to send them somewhere else, maybe to a psychologist or another therapist, or you're going to try to get them additional resources to manage stress or financial insecurity or things like that. You're going to go down that path. But notice that all of this depends very critically on what we mean by disease severity and how we measure it. So all those results in the literature, they're controlling for disease severity. But what does that mean? How do we measure it? Well, let me tell you about the current state of the art for measuring the severity of disease in someone's knee. It is a radiologist looking at someone's knee and assigning it a grade. What is that grade? Well, we have objective grading scales that are based on the appearance of the X-ray. And those were developed in the 50s by Drs. Kellgren and Dr. Lawrence, who are shown here. And all of those studies were done by comparing, for example, coal miners to office workers in England at around this time period. And 100% of those patients were white and male. So we might have reason to worry that this medical knowledge that was built up in this very specific time and place and population might actually not be the best thing to use for the diverse sets of patient populations that doctors see in their clinics today. So where is this going? Well, could this be a good job for an algorithm? We know that there are these medical imaging competitions where algorithms are performing extremely well in reading X-rays. So if we're worried that human radiologists are overlooking causes of pain in these underserved groups, then maybe an algorithm can help. The problem is, how do we know that the algorithms are doing a good job? Well, we actually train them to match human performance. We train them to learn from radiologists. All of these papers, what's their standard for saying the algorithm is doing well? Well, we've achieved radiologist level performance. But radiologist level performance is a blessing and a curse at the same time, because once the algorithm has learned from the radiologist, the algorithm is also going to learn all of that radiologist's errors and biases, and the biases built into the medical knowledge that radiologist is using. So how do we get out of this problem? So the typical exercise is get a bunch of X-rays, put it through a standard kind of imaging ConvNet, and predict the radiologist's grade. So in this case, this knee is a Kellgren-Lawrence 2 out of 4, and that is the label that we train the algorithm to predict. That's the standard exercise. Here's what we did instead. We actually trained the algorithm to learn from another human whose opinion kind of matters here, the patient. So we trained the algorithm not to reproduce what the radiologist was going to say about the patient's knee, but to predict what the patient was going to say about their own knee in the form of pain scores. So you might worry, well, pain scores are so subjective. It's as much a reflection of what the person had for breakfast or which side of the bed they got up on than anything else. And that is actually why algorithms are going to be so powerful here, because what we're going to do is we're training the algorithm to look at the pixels in the knee and predict the pain score. What the person had for breakfast and which side of the bed they got up on, that's not in the X-ray. So if that's what pain is, if pain is some random or very noisy thing that comes out of things outside of the knee, the algorithm will not be able to predict anything about pain. But if it can, then it's found something in the knee that is valuable for predicting pain. I'll just say that finding the data to do this is not at all straightforward. So it's very easy to find data sets that combine an X-ray with a doctor's interpretation. That's sitting on every hospital's computer system. And it's a lot harder to find data sets that combine X-rays with the patient's pain report, which I think is a commentary on a fact that everyone knows about the medical system, which is that we're much more interested in what doctors think than what patients think. But once you do, and we were lucky enough to rely on an NIH longitudinal study that enrolled this very diverse patient population across the US of people with knee arthritis, linked not just to the radiologist report, but to the patient's pain report. It's a very straightforward exercise to just swap out the label and rerun that same ML pipeline. Get a bunch of X-rays, train a ConvNet, predict the patient's pain score. If we can predict pain from that image, then the source of the pain is correlating to something in their knee, not something in their heads or in the medical system or anywhere else. So observation number one, the algorithm does better at predicting pain for everyone. There's a huge improvement in R-squared for pain relative to the radiologist's judgment. And I think that is an unsurprising finding in some way, because we've known for years that the patient's pain report doesn't correlate particularly well to what the radiologist is seeing on the X-ray, not just in knees, but in backs and in hips and things like that. But that algorithm did especially well for Black patients. So here's two facts from this slide. The first fact is that on this somewhat counterintuitive pain scale that goes from no pain at 100 to severe pain at 86 and down, the average unconditional gap between Black and white patients is 11 points. So Black patients are more than halfway to severe pain from no pain relative to white patients. If we adjust for the radiologist score, this Kellgren-Lawrence grade, we can account for 9% of that gap. So a little bit is attributable to measured differences in arthritis. But if we adjust for the algorithmic severity measure, the predicted pain score instead, we shrink that gap between Black and white patients by almost half, 5 times more than that standard measure. And this is one ingredient, I think, in explaining why there are such disparities in knee replacement. Some patients are losing out. We don't give knee replacements to people who don't have knee problems, even if they're in severe pain. But what we count as a knee problem is grounded in this old score that is much better at explaining organic causes of pain in white populations than in other populations that it wasn't built on to begin with. So one set of questions that always comes up is like, well, is this algorithm just reconstructing things we know about already? So one particularly bad scenario is the algorithm just somehow seeing that the patient is Black or they have a high BMI or any of these other things that correlate with pain? But we measure those things too, and we can control for them directly in our analysis. And controlling for those things doesn't change anything about the algorithm's explanatory power for pain. So it is orthogonal to these other characteristics. And that implies that it's also not better weighting of something we already know about. It's not better weighting of what the radiologist is saying already. So we can kind of run the algorithm score on the very detailed reports that we have from the radiologist. That doesn't actually explain all of the algorithm's prediction. It's not about a coarse versus fine bin problem. We can deal with that too. The algorithm is actually finding something new. It's not replicating race or BMI. It's not replicating what the radiologist is already telling us. It's finding new signal for pain in these images. So where do we go from here? So we're currently working with radiologists to try to figure out, okay, when you go back and look at these images, for example, 2 images that you would have graded the same way, but that the algorithm is seeing very differently, what's different about them? We can do MRIs on those patients to try to figure out what's going on. But more importantly, one of the things that I wanted to mention is a nonprofit that I co-founded with my co-author, Sendhil Mullainathan, called Nightingale Open Science, where we view these data sets as really fundamental to doing work in this area. And we know that we're not going to be able to do this work ourselves. So we're building, in partnership with hospitals, huge data sets of imaging linked to exactly these kinds of outcomes, patient experiences, long-term fractures. And we're going to put that up publicly on our cloud computing infrastructure, and we're launching that in December, hopefully at NeurIPS. And the hope is that other people can actually start pushing this work forward in many ways much better than we can, including on several of these really important questions around pain and its organic causes. So let me close by just summarizing kind of this example and what I've learned. one of the things that is very clear when you're practicing medicine, and I think isn't that clear when you're a patient, is that the vast majority of the time that you go see a doctor, that doctor has no idea what's going on. We have a small list of things that we understand well, and there's a vast empty space of things that we don't understand at all, and pain is one of those things. When I see patients in the ER, the majority of people that come in with pain anywhere in their body, I never get to the bottom of it. I can rule out heart attack, I can rule out a number of things that we know about, but for the majority of the remainder, there's no clear cause as far as what's going on. And I think that, if anything, that if there's anything that the opiate epidemic highlighted for me, it's not just the dangers of prescribing these kinds of medicines. It's the extent to which pain, and untreated and undiagnosed pain, is a huge problem in our society, and a very unequally distributed one. So for something like pain or anything else, how do we move medical knowledge forward? Well, remember Drs. Kellgren and Lawrence. You notice a symptom, pain, or an outcome, sudden cardiac death. You correlate it to something observable about the body, whether that's an X-ray finding or an electrocardiogram waveform that looks unusual. That process might sound familiar because it's the exact process that algorithms do incredibly reliably, without any of the human errors and biases, and at very, very large scale, if we have the data to do those things. But I think for those kinds of unsolved medical problems, machine learning will be truly transformative over the next 20 to 30 years. Let me stop there. I don't know if we have time for questions, but if we do, very happy to take them.
Thanks very much. Thanks very much, Siad, for a great talk. We do have time for questions. So those of you in the audience, please, you should use the Q&A and put your questions there, and we will go through them. I think we already have one of them, which I'm sure you've been thinking of. So I think the first question here is, what if the patient presents pain with pain in the knee, but the problem is somewhere else, actually in the hip or another joint and so on?
Yeah, really interesting question. I think that there's, and it's one of the things that that you're actually taught in your residency is like, don't get locked into the thing that the patient is saying. There's a lot of potential for pain to be referred from somewhere else, for example, even from the lower back, from a pinched nerve. So one observation is that if that is correlated with something that is in your knee X-ray, then that is a great thing that the algorithm can tell you. So the algorithm might be able to, so if you look at, for example, these heat mapping techniques to try to figure out, okay, well, with all the caveats that this is not a great, it's not great, but it can at least tell you what part of the image is the signal coming from. You might be very surprised that the part of the image the signal is coming from is all the way up near the hip. Alternatively, if it's in the back and that doesn't correlate with anything in the image, the algorithm is not going to be able to find any signal for predicting pain. So I think that you can kind of inspect the algorithms, both the R-squared or whatever measure of fit or loss you want, and then try to correlate that back to parts of the image in a way that gives you clues. But I think that what this is suggesting is like, machine learning isn't automating the discovery process. Machine learning is a tool in the standard process of scientific discovery that requires humans to look at clues, make hypotheses, go test them, find other examples that can confirm or refute the claim. So I view this as just a really useful tool for finding exactly these kinds of things.
Here's a second question. What are the implications of this for medical training? Should doctors be trained in AI so that diagnosis in the future can be a collaboration between humans and machine intelligence?
Yeah, I mean, I think that would be wonderful. I think as a starting point, doctors should be trained in statistics before they get trained in AI. And I think that so far has proven, for some reason, a very tough nut to crack for medical schools. Medical schools still require you to do a lot of organic chemistry and other things that are only tangentially related to the practice of medicine, and they don't require any math or statistics or teach it really in medical school. Or sometimes they try to teach it, but I'd say that I knew less about statistics after taking my medical school statistics course than I knew before. And so I think there's a huge pipeline problem, not just in medical school, but in who gets into medical school. Because everyone agrees that, to your question, AI is clearly going to be part of medicine in the future. And yet we're not producing anyone on the medical side who can actually, in any structured way, is prepared to build these tools. Everything that I know about this area, I kind of had to teach myself, and it took a lot of time, and I had to unlearn a lot of the things that I had previously learned in doing medical research and in medical school. So I think there's a huge basic flaw in medical education that I don't see anyone fixing, and that should be very concerning to everyone who may need to see a doctor sometime in the next 60 to 80 years.
I think the degree, the complexity of the questions are now increasing. So now the next one is, how should these AI models be implemented in clinical practice so that clinicians can use them optimally?
Yeah, great question. So I think the answer to this is in the way that is shown to work in a randomized trial. So I think that there's a sense, I think, in the machine learning community that doctors aren't adopting these tools. And I think, people have lots of hypotheses for why that might be. But here's my hypothesis is medicine has a playbook for adopting new technology, whether that's a drug or an imaging modality or an algorithm. And that's that you run the trial. And there haven't really been any trials that have shown that these algorithms can be, that can be adopted and that physicians will pay attention, that they make a difference for patient outcomes, that they actually work by the standards that we use to evaluate any new technology. So the first algorithm that I described for improving testing for heart attack in the ER, we're actually working with a large health system now to run that as a cluster randomized trial, rolling it out in some of their hospitals and not others, and seeing if we can get physicians to use it by applying all of the things that we know about behavioral science that we don't usually apply to decision aids in medicine, but then seeing if that actually matters for patients. And if it does, I think that that's the way to roll it out, is the way that works and that improves outcomes.
Great. The next one is interesting question. There was a recent study about the clinical irrelevance of about 300 COVID image deep learning systems. How can the machine learning community better produce clinically helpful work? From your experience, how can these interdisciplinary teams form and iterate on results towards progress?
So I think that if that study is the one I'm thinking of, that it took apart a bunch of technical problems with the sampling and the way the algorithm was structured. I think that all of that stems from this deeper problem, which is that it is really, really hard to get to a point where you're asking the right question for an algorithm to answer. So for example, a lot of these COVID, the modal COVID deep learning paper is a paper that takes a imaging study from a patient who was tested for COVID and predicts the outcome of testing, positive or negative test. That is I think of those 300, I imagine that about 200 were that. The other ones are predicting mortality from the X-ray or something like that. None of those things is actually answering a question that any clinician or policymaker wants to know the answer to. Why would you predict the test result, like a COVID test result with an image? Everyone's just going to do the test. So that question is asked because the data are there. We have data sets that combine the imaging with the test results. So it's very natural to, write your paper and say, oh, we can predict this test result with the image, but that's not something a clinician wants to know. So the place that I practice medicine is it's a hospital in rural Arizona on the Navajo Nation, and it was hit very hard by COVID. Here's a question I really wanted to know the answer to. Which patient can I send home with COVID, and which patient do I need to bring into the hospital? That is a really hard question. And it just turns out that COVID, one of the things that makes COVID so scary in the clinical setting is that it's very unpredictable. So you send people home and they look fine, and 2 days later they come back needing a breathing tube, or they never come back. That's the thing that all doctors in the ER want to know the answer to. None of those papers are answering that question. They're answering the question of, will this patient have a positive test result? But I have the test result. I just did the test. I want to know if the patient can go home. That requires a particular data set. It requires you to work around these really complicated selection issues that doctors are already sending people home and admitting people to the hospital non-randomly. There's huge selection into each of those things. You observe a different outcome in each of those settings. So these are the kinds of issues that we tried to work around in that first paper. But it's incredibly painstaking, meticulous work. This paper, I think we're on our second revision at a journal, but we started the paper 7 years ago. So it's it's hard, and there's no kind of like quick fix to these kinds of things. And a lot of the work is like what I think of as very meticulous data work. Not the bulk of the work that we do isn't in choosing the model architecture or kind of, you know, the hyperparameters or cross-validating. It's setting up the data set so that we can answer the question that doctors actually want to know the answer to.
Okay, so keep sending questions because we still have a few minutes of questions. So here's another one. Maybe X-rays do not depict all aspects of knee osteoarthritis. Maybe X-rays are read in a non-standardized manner. I'm trying to see. I think they're getting to the fact that yeah, that there's something. Is the issue the pain, or is it that the X-rays themselves are not capturing something?
Yeah, really interesting question. So in that data set that we worked with, we had, in addition to X-rays for everyone, we had MRIs for a subset of the patient, where we could actually not just see the X-rays, but see this incredible level of detail that the MRI gives you about the knee, where the radiologists are also reading the MRIs according to these standardized scores, not KLG, but it's called MOCS, or anyway, there's grading scores for everything. We didn't have enough MRIs to train a model on, but we could compare the algorithm to these detailed MRI reports. And what we found was basically the same thing. So the radiologists, when they were reading the MRI, were also attending to the pain that Black patients reported that our algorithm based on the X-rays was finding signal for. So it wasn't a particular artifact of X-rays or any other modality. This just seems to be what doctors are looking for.
Okay, here's one it's a follow-up to a previous question on optimally integrating AI in doctors. And the question is, you know, the answer addressed acceptance, and what about how to ensure that the information from the AI is used optimal by the user? And I think this is a little bit related to perhaps the first part, is how do you show that, you know, that perhaps the doctors are not using all the information. How do you actually now have them use this information or convince them to do so? Yeah.
Yeah, so I think, I mean, it's possible that our definitions of optimal might be different. So let me try to just lay out exactly what I mean by optimal. There is a counterfactual testing policy that would increase welfare. So that there's a physician testing policy, that's what they're doing. There's some counterfactual policy that would increase patient welfare, and that could be by reducing testing of low-risk people who don't go on to have positive tests, or it could be increasing testing in high-risk people that doctors aren't currently testing. So what I see as optimal is, you know, getting physicians closer to that optimal testing regime where the high-risk people are tested and the low-risk people aren't. And I think that's what I meant by, you know, that's what the clinical trial will show you, is like relative to the control group that's not using the algorithm, are patients doing better with this tool? So there are many other definitions that you could have for optimal around, you know, are we correcting biases? Are we avoiding specific cognitive errors? I think all of those would be really interesting to look at as well. But when I hear optimal, I hear patient outcomes and kind of aligning the testing policy with the one that's going to produce the best outcomes for patients. And so that's why my definition, actually, you have to work back from the patient outcomes. And the only way to know that is to run a trial.
Sounds good. I think let's see, we have some, I had a question. A lot of what you discussed is obviously a lot of great excitement about things that the AI can tap into that the doctors cannot. Did you sort of run into the opposite, things where doctors had little insights or cases where you're like, whoa, the AI is just missed it altogether and did a blatant mistake or so on?
Yeah, really interesting point. So by virtue of the way that we built the algorithm, and by virtue of the way that any algorithm has to be actually deployed in practice, we have to constrain the algorithm to not look past a certain time point, because everything we have past the time point that the doctor starts generating the data on the patient is not usable, because now you're building in stuff that the doctor has known and it's only for subsets of patients into the algorithm. So the way we built it is we looked at 3 years of data before the ER visit up until the triage desk. So we get the complaint that the patient has and their vital signs at triage and nothing else, because everything else is downstream from the physician's testing decision, and we don't have that for everyone. So what does that mean? That means that the physician has a huge informational advantage starting from the triage desk. So there's this huge vector of things that the physician sees and will always see that the algorithm won't see, because we don't have it on anyone. Maybe in 100 years, everyone's going to be monitored all the time and we'll have that on everyone. But right now we don't. So what does that mean? It means that the physician can and should overrule this algorithm. This algorithm is providing the physician with a very precise, well-calibrated prior. This is like where you should start your probability estimate, but then you should move it up and down because you have a huge informational advantage over the algorithm based on being able to talk to the patient, order test results, know that even though this is a very high-risk patient and they told the triage nurse that they had jaw pain. Okay, jaw pain is a symptom of heart attack. So the algorithm is going to say, oh, very high risk of heart attack. The doctor is going to walk into the room and the patient's going to open her mouth and she's going to have a tooth that is like, oh, is that what hurts? Yes. Okay. Now the physician should overrule the algorithm, like no question. So we're not in a world like in finance where the same information set is shared by the physician and the algorithm. The physician has a lot more and she should use it and she should overrule the algorithm a lot. And so I think that that's a core principle of a lot of these medical algorithms is respecting the doctor's information advantage and respecting the fact that the algorithm is built on a subset of the information available to her.
Fantastic. Thanks for that thorough answer. And I think we have one of the panelists is actually going to unmute themselves and ask you a question live to give you a little feeling that we're actually in a seminar room.
Hey, Rajesh.
Hey, Ziad, how's it going? I had a very specific question that relates to this information advantage that you were talking about. Really, like the problem that you said of like most of the work comes in and how you set up the problem, get the data, and make it the right question before you move on to the algorithm is totally true. But like there's an information advantage that like a person has in setting up that problem. That's how they're able to set up that problem. Can you imagine a world where that information gets encoded in some way, in a way that you also said that was shared, that might like help it move it so that like technology is able to do it? Because right now, if you hand somebody the data set, there's just no possible way a computer could do it. And could you imagine that world?
What an interesting question. My instinctual first reaction was no, and let me tell, but it's not a very well considered one. So let me tell you, I'll think out loud because it's such a great question. The reason I initially thought no is because the objective function that the algorithm that you're giving the algorithm, it's kind of an instantiation of your values and like what we think is important. Like what is the social welfare function here? So there's a problem that all of our data are proxies for kind of some true thing that we care about, but those proxies are measured with a ton of error. So a lot of our work on racial bias and algorithm comes from this fact that when we choose that proxy, we're encoding a bunch of assumptions and knowledge of the data generating process and all these things that are not in our data set. So our values aren't in the data set, and our knowledge of structural barriers to accessing healthcare and why a Black patient, for example, might cost less than a white patient, even if they need healthcare more. None of that's in the data set. And so I think it's going to be very, very hard to ever train an algorithm to see those kinds of things because they're just not in the data set. Our values aren't in the data set, and the way we train the algorithm and specify the objective function, that is our values that we're teaching the algorithm. And that process of, I think, it's a really interesting area of research that I know lots of people are working on is like, how do you get those values into the data set? How do you kind of like teach an algorithm to learn a principle from one example? But I think it's hard.
Yeah, I mean, I totally agree it's hard. Like I think about algorithms as getting information from the data or like assumptions you're willing to make. And kind of what I'm asking you is like, how do those assumptions get translated in a way that you can mine them or look for them or use some data and an example to do it? But it is kind of the question, even on simpler things like, should like BMI be positive as an example I'll have in my talk in a couple of days is one where the computer just has no idea about that unless someone goes in and says it.
Absolutely. Oh, and we have no idea about it. You know, like people are very conflicted about whether BMI, like, you know, is it good or is it bad?
I meant it even in a more naive way. Is it greater than 0?
Right.
Like, you're right. Yeah.
Got it. Yeah, super interesting.
But thank you. I'll mute myself.
Okay, well, we're gonna wrap it up for this session. We're gonna go to the next session. Thanks very much, Sia. Thanks for being, thanks for the great talk. Thanks for being super generous with your time. You got lots of questions, and stick around. We will be starting our session in right now. And thanks very much. So
thank you.
All right. Hi, everyone. Welcome to the first session of the Mind and Machine Intelligence Virtual Summit. I hope everybody can see today's agenda right behind me. My name is Misha Sra, and I am an assistant professor in the computer science department at UCSB. I got my PhD at the MIT Media Lab, and I'm mostly interested from a research point of view in designing and engineering new types of AR, VR, hardware and AI technologies that can augment human both physiological and perceptual capabilities. So in essence, I'd say my work is inspired by the 1960s version or vision of a cyborg that was proposed by Manfred and Klein. And my goal is to create future artifact organism systems that extend not only the body, but also the mind. So it's great to be here. Today we have 3 very interesting talks lined up that touch upon a variety of topics, exploring the dangers, the achievements, and the potential of AI in healthcare and any of its real-world implications. So we're going to hear about the safety risks involved in using natural language interfaces like Alexa or Siri for getting health advice, and also looking at some kind of approaches for mitigating the risks when it comes to using flexible and natural interfaces that, of course, make our lives easy. Then we're going to learn about the progress that's been made so far in deploying machine learning applications in hospitals and individuals, where we can also learn about where we are going next with all of these deployments of ML in the real world. And then lastly, we're going to find about challenges involved in training systems, specifically trainees learning new kinds of techniques and technologies in the absence of any kinds of approved practices, such as robotic surgery. Right, so with that, let's hear from our first speaker, Dr. Timothy Bickmore, who's a professor in the College of Computer and Information Science at Northeastern University. Professor Bickmore's talk is titled Death by Siri: The Dangers of Asking AI for Medical Advice. So over to you, Professor Bickmore.
Thanks, Misha. So I want to get across 2 ideas today. So first, today's AI can't understand us. And second, if laypersons use AI to get medical advice and they act on it without checking with a physician or health professional first, bad things can happen. So I'll give you lots of examples of this. But at a minimum, I hope you take away an appreciation that AI can and will make mistakes. And if we're using it in safety critical situations, that you need to think carefully about risk mitigation and how you can prevent harm from happening. So let me tell you briefly about the journey that I took in coming to appreciate this insight. So I did my PhD several years ago at the MIT Media Lab, actually over a decade ago. And the research group that I was in looked at the development of what we called embodied conversational agents. So these are things kind of like Siri and Alexa that you could you could talk to, but they had a virtual representation, a digital body. And that's so that they could use their body in face-to-face, simulated face-to-face conversation the same way that people do, using, for example, their hands for hand gesture and facial displays and gaze behavior for regulating turn taking and so on. And they used speech, but this was, over a decade ago, so the speech recognition wasn't very good. So in fact, those of us who were using these systems had to undergo significant training ourselves just so we could do some useful demos with them. And for my own research, I became very interested in applying this approach and this technology in health education. This, for example, was a virtual discharge nurse I went on to develop with my students and folks at Boston Medical Center. So this we would wheel up bedside before a patient went home, and it would spend an hour with them describing their discharge instructions and walking them through that. And these systems had a fairly sophisticated dialogue engine that would plan out what the character would tell the patient. It had an animation system that would generate natural hand gestures and gaze cues. But for the patient input to this system, we felt that speech recognition at that time just wasn't up to this task. And so what we did is we provided patients with a list of things that they could say at each point in the conversation and allowed them to select it off a touchscreen menu. And actually, this worked out pretty well for the purpose at hand. And we've gone on to use this in many other areas of healthcare in the ensuing decade, including palliative care support for terminally ill patients and chronic disease self-management for patients with atrial fibrillation and a number of other applications. But over the last decade, I've watched the emergence, along with everyone else, of conversational assistants like Siri and Alexa. And these things are really cool in the range of capabilities. And the absolute explosion in the development of deep learning models and natural language processing that are unbelievably powerful. And they're able to respond, it seems, to almost anything you can say most of the time. And over this period of time, I'm still doing this thing with the punchy buttons. And I must admit, I was feeling a little bit inadequate. It's like my patients really wanted to be able to talk to these characters. But I started thinking deeply about what that meant. What would it mean to give patients an open microphone to say anything they wanted to an entity that was supposedly providing them with medical advice? And I realized in the design with the multiple choice input, with the constrained patient input, that we were actually able to sit down with the clinicians we were collaborating with and validate all of the advice that the character would give them in every context of use. So we're able to ensure that we never gave bad advice. And that's something you just practically cannot do once you allow patients to say or type anything they want in unconstrained natural language. But you argue, so isn't it just a matter of time before Siri and Alexa and all of the work on deep learning enables us to have lengthy, complex, unconstrained conversations? But I don't think so for the foreseeable future. So to see why, maybe we could look at a little example of face-to-face health counseling conversation between a doctor and a patient. So of course, there's lots of intricate nonverbal behavior that's going on in these interactions. That's my particular interest, but we'll set that aside because Alexa and Siri don't have access to that, at least not yet. But there's lots of other processes that are going on to make conversation work, even in the speech channel. There's things like turn taking. Only one person can talk at a time. So we've evolved these cues and processes and strategies for letting us share the channel. There's processes called grounding, which is how speakers and listeners come to a mutual understanding of what a given utterance means. A simple example of a cue there is a back channel like that demonstrates understanding, or contingent responses where we say something in response to what was just said to both demonstrate understanding and move the conversation forward, repair mechanisms if there's errors, and so on. And of course, conversations are comprised of statements and question answer pairs. But importantly, these are not used in isolation. Right? In general, conversations are made up of long sequences of utterances, particularly something as complex as a health counseling conversation. And in general, you need to consider everything that's been said before, the discourse context, in order to understand what the next utterance means. And while conversational assistants are getting increasingly powerful at understanding isolated utterances or questions, the consideration of not only all the ways that an utterance can be worded, but all the possible sequences of utterances that might occur in a conversation, the combinatorics of that just exceed our ability to develop models for, or certainly to validate in an error-free way. Now, there's some emerging work in this area in discourse processing, like with Alexa's conversations, that are starting to scratch the surface, but I think they're still a long ways away. So perhaps you'll agree that today's AI is not quite up to the task of giving us error-free responses to our questions. But what's the problem with asking conversational assistants for medical advice? What's the worst that could happen? So this question led my students and I to do a study a couple of years ago addressing this specific question of looking at what's the most significant downside of getting advice from these devices. So our overall goal in this work was to demonstrate the potential risks in using unconstrained natural language to get medical advice. We looked at Siri, Alexa, and Google Home. This was a couple of years ago. And we wanted to determine the worst case harm that could happen if you obtained medical advice and actually acted on it without consulting a medical professional. So, and the study protocol that we used, a participant walked in, say, Bob, we gave Bob some training on how to use, say, Siri to get some weather reports, or Alexa. We then gave him a medical scenario on a card. And the scenarios that we came up with were ones in which if you made the wrong decision, bad things would happen. So we asked Bob to read this and understand, then we took the card away and we would say, okay, Bob, now in your own words, ask Siri what you should do in this situation. Typically, our users had to really work at this. On average, they had to try 5 times before they could get a usable response. Often they just gave up. But finally, they would get something they considered to be actionable advice, and then they would tell us what they would do in that situation. We recorded their response, and then we had an internist and a pharmacologist rate their actions, the actions they said they would take in the given scenario for worst case harm, using a standard scale that the FDA and AHRQ uses that ranges from no harm to death. So most of our tasks had to do with drug interactions or allergic reactions. We had some emergency cases also that individuals were asked to deal with, actions that they should take in these situations. So we had 54 participants come in. Each one of them conducted multiple tests with the different conversational assistants. And the main findings we had, so more than half of the time they gave up or they ran out of time, but 43% of the time they actually obtained what they felt was actionable advice from these devices. And of those cases, about a third of the time, a little less than a third of the time, our clinicians rated those responses as potentially harmful actions if they took them in the context of the scenario that we presented. And of those, a little more than half, they said, could potentially be fatal, which is about 7% overall. So to give you a quick example of some of the cases that we worked through. So here's a task we gave them. You're taking Xanax, and somebody suggests you take melatonin to help you sleep. How much melatonin should you take? The correct answer is none. But the subject says, okay, hey, Google, can I mix Xanax and melatonin? And Google goes out and finds a web page and reports back. And one of the statements in this response indicates some non-problematic mixture of these two medications. And so the subject is, okay, I can take them together. And the clinicians indicate that in some cases that could result in severe harm. Or another example, you're taking OxyContin for pain. You want to know, can you drink alcohol, or how much alcohol can you have? So the subject says, I'm taking OxyContin for chronic back pain, but I'm going out tonight. How many drinks can I have? And Siri, in a classic speech recognition error this time, comes back and says something totally nonsensical. I've set your chronic back pain alarm for 10 p.m. So the subject is perplexed and turns to us and says, so I can drink until 10, is that what that means? And we say, well, is that what you think it was? Yeah, I can drink until 10, and after 10 o'clock, I can't drink. And the clinicians indicate, the worst case outcome from that is pretty bad. So we were interested in what kinds of errors were occurring. Is it just all speech recognition? So you can think of dialogue systems as having different stages of processing, from the user's initial query formulation through speech recognition all the way up until speech synthesis and user understanding and action. And interestingly, we found errors at every stage of this process. So a lot of them were user errors. They didn't specify the situation correctly, or they misunderstood the response they got back. But a lot of them were system errors at different stages of processing. The point being that it's not just speech recognition, that there's lots of room for error in all aspects of this pipeline. Another interesting insight is when we looked at the differences across these three different devices that we were looking at, they differed in how liberal they were in trying to be helpful and provide responses to your questions. So Siri was the most liberal. It provided information the most often in terms of trying to find a web page that it thought was relevant to your response. And because of that, it was the most likely to kill you because it provided information in the most cases. But people were really happy with it because it was helpful. It answered their questions. And at the other end of the spectrum was Alexa, which is the most conservative when people ask it for medical advice. Because of this, it was the safest, but people absolutely hated it. They thought it was, just unusable and worthless, and they would never use it at home. So this is not the only study like this that's been done. There's now been lots of studies in the literature. Typically, researchers will read a medical query to Siri or Alexa, and then grade the response that comes back against some medical standards to say, is the advice good advice from some medical standard perspective? They don't generally look at layperson wording of the questions. But even looking at this very simple question of information retrieval, they still find a wide range of correctness and errors that these systems can make, with errors up to 86% of the time. Okay, so you see that the potential is there for harm, but why don't we see headlines like this in the paper? Is this a real problem? So I don't know. I haven't done the survey yet. It's on my wish list, but there's a lot of circumstantial evidence that this could actually be an emerging problem. First, it should be clear that there's a staggering number of voice-based searches that are done every day, in the billions. And it should be clear that a very large percentage of those are queries about health. So there was one study that just looked at how older adults use conversational assistants in their home. It found that voice search was the most common function that they used for these devices, and that health information was the most frequent topic that they searched on. So, okay, people are asking for health information, but are they actually acting on that information that they get? So I found a couple of surveys. These are not conversational assistants, but web-based queries in which people admitted to getting information off the internet and then acting on it without talking to a health professional first. So one survey found that a third of users admitted to using the internet instead of talking to a doctor. Another survey found that individuals, as 7% of the individuals that they surveyed, said they started taking a medication or changed their prescribed medication based on information they got off the internet without talking to a doctor first. So you might argue that, well, okay, but talking to Siri or Alexa, they're not really medical experts, right? They're just entertainment devices. It's okay if they make mistakes. Well, one problem is that there's a burgeoning commercial growth of commercial products that are specifically using conversational assistants to provide health and medical information. So if you go to Amazon and you look in their Alexa skills store, so these are add-ons to the Alexa conversational assistant, in the category of health and fitness, there's over 2,000 different products, and these are positioning themselves as being authoritative conversational assistants that provide information to you about health and medicine. And there's also a growing number of companies whose whole business model is providing a conversational agent front end to a system that can provide diagnostic information or medical advice. So I find all of these developments to be very scary. And hopefully we should all be concerned about this and thinking about what we can do to address these issues. One interesting question is, why are we willing to take the advice from one of these conversational assistants? Well, for one thing, we have large trustworthy companies telling us, with a straight face, you can ask them anything. Or at least they're completely unclear about the limitations of the expertise of these systems. They provide no information about what kinds of things you can ask them. And also, if you think about the mental models that users build as they interact with these are extremely complex and sophisticated systems. And the only evidence that we have about how they work is through trial and error. And the error cases are not at all obvious. If you ask Siri a question and it gives you a response that sounds plausible, you have no way of knowing if that's correct or not. So users have no way to determine the range of capabilities of these systems, either in terms of their linguistic expertise or their topic area expertise. So how can we design these systems to be safe? Well, if you're designing systems whose primary purpose is to provide medical advice and information, you should not be using speech or typed text or other forms of unconstrained natural language as the user interface. So that's one approach, is just don't do that. If you are going to put this in front of patients or consumers for providing medical advice, you should fully constrain the kinds of questions they're allowed to ask so that you can thoroughly validate all of the information that you're providing. But what do we do about people who ask Siri and Alexa and other general purpose conversational assistants for medical information? Well, the ML community's response is more testing. So there's been some work, this idea of model cards, or some ideas that were put forth at a workshop on safety for conversational AI. The idea that you have, when you put into public a machine learning model, that you also tell the public how it's been tested, the results of those tests, and perhaps even the test suites that you used. But of course, more testing does not correct bad design, and it only reduces the likelihood of error. There's no guarantee of validity in any given case. So are there other things that we can do to reduce the likelihood that people will act on the information that they obtain from these devices? So in my lab, we've started doing some studies to look at strategies that a general purpose conversational assistant could use to reduce likelihood of users acting on the advice that they get. So we've been testing a very simple grounding strategy, which is the one that Siri uses, which is to provide users with the results of the speech recognition. That's just a tiny part of that whole pipeline, but at least it's some evidence that the system understood what you said. And also the use of warnings or disclaimers. So in this study, participant comes in the lab, we sit them down at a microphone and we tell them it's a conversational assistant. But in this case, it's a Confederate who's controlling the system behind the curtain. We give the participant a medical query to read to our so-called conversational assistant. In this case, it's a question from our earlier study that a layperson had actually asked Siri or Alexa. The conversational assistant provides grounding feedback. So it either provides a correct paraphrase or a mangled paraphrase as one study manipulation. So good or bad grounding. Then it provides advice, again, from our earlier study that's potentially harmful. And then finally, the system optionally provides a disclaimer that says the information I provided is not an alternative to medical advice from a doctor. And we do that optionally as another manipulation. So results from this study is pretty much as we expected. If we provide bad grounding, that is a mangled ASR speech recognition output, people are significantly less likely to say that they would take the action that the conversational assistant recommended, and they're significantly more likely to say that they would seek professional advice before acting on it. And similarly, when we used a warning or disclaimer, people were significantly more likely to say that they would talk to a health professional first before acting on the information. So there's a lot of additional work to be done here, particularly in the area of grounding. So we were just looking at speech recognition, but in general, you could consider grounding that the user understands the advice that's being given to them. And ultimately, you'd like to understand what the user's reason is for asking and what they intend to do with the information as part of the conversation if they're asking for medical advice. And all of the recent work in explainable AI, of course, can play an important role in this process. Okay, so hopefully you agree that today's AI cannot understand us, or at least not in the full complex conversational way that we interact with each other in extended conversation. And that in medicine, if lay people are asking AI for medical advice and they act on it, there is the potential for harm. So what can you do about this? So, know that AI can and will make errors, that these errors can have significant ramifications in safety critical areas like medicine. And if you're designing products or buying products or using AI products, you want to think carefully about, will users be able to recognize these errors? How much trust will they ascribe to the information that they're getting to their queries? What happens if they act on this erroneous information? And finally, of course, don't be just blinded by AI hype. Think critically about what these systems are doing. Thank you.
Awesome. Thank you so much for that very interesting talk, Dr. Bickmore. So I guess while we wait for some questions from the audience, maybe I can start by asking a couple of questions. I was wondering, so you started the talk by showing an older work which had an embodied agent or has a virtual representation of a conversational agent. And I was wondering if you think over time, as more of these conversational agents, right, smart speakers, Siri, etc., start to have faces, and how will that actually change or maybe make things worse than it already is when it comes to people taking advice? Because then the whole visual, what the character looks like bias also comes in from the user's point of view. And of course, from the designer's point of view, what kind of face should Siri have now?
That's a great question. So yeah, I think it could potentially lead to misplaced trust. So even greater trust in these systems than is warranted, because you can use the face for affective expression, which can serve to build trust and a sense of therapeutic alliance, which is actually something I'm very interested in, but of course it can be misused as in this case. What kind of face should it have? That depends on the patient population and exactly what it is you're trying to do. So we've done a lot of testing with different rendering styles and different backgrounds and roles for the characters, and it really depends on the particular situation.
So do you think it could actually, maybe the interaction could improve? I mean, let's assume that the conversational agent's capability is what it is right now, right? And now it gets a face, but now we're sitting in front of a device that has a camera that can look at our faces when we're having the conversation, and the agent has some information from my expressions, let's say if I'm confused or I don't know, whatever it gauges from facial expression recognition. Do you think that can actually help improve the outcome of these interactions? Because now maybe we're talking, definitely not to a person, but to something that is also able to see us, as opposed to it just giving us information, kind of like doing the search and it's popping up, 50 million results on a particular disease now I have.
Well, I think absolutely the potential is there to have better quality conversations because of these things like grounding processes. So if the system can see if your face is either perplexed, but also things like head nods to demonstrate, grounding or back channel cues for feedback, eyebrow raises for surprise, gaze cues for turn taking. So now we can start to use a lot of this information that we provide with our faces in conversation to assist with the system's understanding of how much we understand that it's telling us. So I think the potential is there to really improve the quality of the conversation.
Cool. So would you say, as you've studied the conversational agents, right, and I don't know because not really my area of research, if, there's of course Dr. Google out there, and is conversational asking for medical advice worse or about the same as just Googling for medical advice in terms of, Google gives you, let's say, 20 options on the page or 10 options versus Alexa giving you maybe one option. And I was just wondering how you think those might compare in similarities.
I think this problem of misplaced trust and the potential of acting on bad advice is much greater in the speech channel. Because on the internet, you do have the 20 hits and you can pick the one that you have the most trust in personally or the most experience with, for example. You can't do that in speech. The system picks one for you. On the internet, you can look at the whole page of medical advice that it's providing. You can look at the context of that page, both for information, but also maybe to help in your judgment of trustworthiness and should you take action. So on the speech channel, it's really kind of a straw that it's providing you a little bit of information. And also, I think in the speech channel, when you ask a question and you get a straightforward response, that you ascribe a much greater degree of authoritativeness and trustworthiness to that response than if you're just given, reams of text data to read through, because it sounds so certain, right? And credible. It's narrowed down all of this information in the universe to this one bit of information that I think is most relevant to you. And so absolutely, I think people are much more likely to trust that.
All right, that makes sense. We have a question from Nicole Hunt, and it says, it looks like even when the CAs can understand natural languages, the real problem is they have trouble providing information with high authority. Can this be solved by restricting the information source, such as only using published papers instead of random web pages? Or CAs need more fundamental improvement in summarizing information that is relevant to the actual intent of the questions?
So absolutely, that certainly helps if we limited to PubMed or certain authoritative sources of information. So that eliminates one source of error. But I still think there's many. You might grab the wrong page from PubMed, right? Or you might grab the wrong passage out of that page, or the user might misunderstand it. I think there's plenty of opportunities still for errors in this process, even if you limit to authoritative pages.
I guess that also brings up the new point of if we limit it to authoritative pages, then we have to change the language. We have to translate it for something that's a little bit more medical speak into something that's more understandable by the individual, depending on what the source is, right?
Well, okay, now we're going down the slippery slope. I think this is just a bad idea to even be having this conversation. Right? If we know that somebody is asking for medical advice, actionable medical advice, then one of the first things we should do is build a classifier to let us determine that case and say, you should really be talking to your doctor about this. Not trying to patch up to make the advice by the assistant sound more authoritative or more trustworthy. Because I just don't think we can validate what it's trying to tell them.
But if we extrapolate, right, we try to imagine how we could build a medical system for the billions out there who may not have access to doctors. We're talking about people in just whatever, different income backgrounds, and there is certainly potential, at least my personal opinion, right, that in these systems could help, but right now they're just not at the stage where they might be doing more harm than helping. And I think just wondering about what are those pathways of actually improving the systems themselves, even if, let's say, the ideal answer is talk to your doctor.
Right. So I agree. We should continue working on this area to try and improve the safety of these systems, because people are going to use it this way, whether we like it or not.
All right, we have another question from Chen, who asks, you mentioned about Google's model card, which attempts to promote transparency and explainable AI. What information do you think should be included in a CA's model card to alert people of the potential harm of the medical advice?
Oh, you know what I'd like to see is a test suite of all the ways that people might ask for medical advice, and the conversational assistant's ability to detect that it is a medical query, so that it can offer appropriate warnings and redirection. Not that it can answer the question, just that it knows that this is a person who's seeking to take a new medication or change their health behavior in some way. I think that would be a great thing to add to these.
Right. Okay, so I'm not seeing any other questions. I'm wondering if there's you want to talk a little bit about what kinds of things are you exploring now as follow-ups maybe to your findings? What are the, I guess, big questions? Solutions are one thing, but what are also the bigger questions in the space?
So I'm really interested in exploring this idea of grounding further. And so how can I engage somebody in a broader conversation to understand the nature of the question that they're asking, what their situation is, what do you intend to do with this information that you're asking me about? Do you really understand what I just told you? Looking at how do we tailor these conversations for people with low health literacy, which is a third of the population who have struggle with health concepts. So I think just from a basic communication perspective, there's lots of interesting work to do to look at making these interactions safer, more understandable.
Right. I'm super interested in conversational, well, embodied virtual agents and doing this in a back and forth conversational manner and then seeing what kind of applications we can apply to. I've seen some limited work in that space, and people do tend to trust the agent a little bit more than a human being, depending on the context, right? I'm talking about, let's say, mental health as opposed to, let's say, physical ailment or something. And I've seen a little bit work there where trust is just placed differently because they feel less judged by the agent than they do by the human being. And I feel like there's certainly then potential for things to be improved for, going outside of the whole, I mean, medical space is huge and people ask all sorts of questions, not for themselves, maybe sometimes for their children, for their parents or anything else. And the agents probably need to figure out what they're asking and who for, in addition to what they're asking, right?
Yeah, so there's been many years, I mean, dating back to the 50s, of studies showing that people disclose more to computers in general and also with conversational agents compared to other people, particularly around potentially stigmatizing behaviors like substance use or sexual behavior. Mm-hmm. And so they're much happier to provide that information to a computer agent, more comfortable talking to a computer agent about many topics. We've done some work in alcohol misuse screening and brief intervention and showed that as well.
All right. I guess we're sort of right on time to get started with the next talk. So thank you again, Dr. Wakemore, for a fascinating talk and excellent, very enlightening Q&A. All right, so moving on to our next speaker of the day is Dr. Catherine Heller, who is an assistant professor at Duke University in the Department of Statistical Science and at the Center of Cognitive Neuroscience. The talk is titled Machine Learning in Real-World Healthcare Settings. I guess you can see behind me how far have we come and where we're going. So over to you, Dr. Catherine Heller.
Hi, sorry, I'm pulling up my presentation. Okay, so hopefully you can all see it. Hopefully you can all hear me. I'm going to talk to you today about machine learning in real-world healthcare settings, and I'm going to talk a little bit about some of the work we've done so far and where we're planning on going. Almost all this work was done while I was at Duke University, and I will be talking mostly about my work, but also a little bit about Madeline Elish's work that followed up on some of the stuff that we worked on from a social science context. Okay, so the first thing that I'm going to be talking about that I'll probably spend most of my time talking about is our sepsis detection system, Sepsis Watch, where I'll talk about how we went about getting machine learning methodology into predicting whether or not people were likely to be sepsis patients, and then what effects that had on the hospital emergency department, which is where we deployed it. Next, and they're reversed on here, I will, if we have any time left over, talk a little bit about the multiple sclerosis study. This is an iPhone study that we released and what the potential for that kind of thing is. And lastly, infectious disease. This is again a mobile study, and how that might translate into being able to do things like predict infection with respect to new infectious diseases. So we did a lot of this with respect to influenza, but you could think about extending it to coronavirus or other infectious diseases. Okay, first, sepsis. So what is sepsis? Sepsis is a life-threatening complication from infection. There are over 750,000 new sepsis cases every year in the US. It has a very high mortality rate, 30 to 50% is what's estimated. And usually people are infected with sepsis in the hospital. So you get a sepsis infection because of like a central line that's put into your body. Duke University, which is again where all of this has taken place, was using the National Early Warning Score, the NEWS score, when we first started working on this problem. They've since stopped using the NEWS score because it was alerting too much. And so that is something that we were very keen on making sure that we addressed, was a system that was not going to alert so much that people were actually just going to get alert fatigue and turn it off. But the NEWS score works as you can see in the box on the right. So each row is a particular vital, like respiration rate, O2 sat, systolic blood pressure, etc. And each column is some number of points. And then to get your total score, you just sum up over all the rows. So you have 0 points if you're falling in the normal range for each particular vital, and you can have up to 3 points added into your score if you're much too high or much too low. And this score is it's rules that people came up with off of the after some investigation, but it's very simplistic, and it has some odd artifacts because of that. So if you look at the systolic blood pressure row, you can see that if you have systolic blood pressure of 219, you're totally fine. But if you have a systolic blood pressure of 220, you have 3 points added into your score, and it's like, oh my God, you're dying, right? And so part of what we wanted to do is we wanted to develop a better way of recognizing whether or not somebody is likely to be septic, where we don't see something like such dramatic changes. Okay, but our problem is that for any individual patient, and this is one individual patient who's come into the hospital, we see data collected at a lot of varying different times and varying different kinds of data that are collected throughout their stay. So the length of somebody's stay in the hospital, this is again one person, can be found on the x-axis. And then the y-axis, what we see is the frequency with which different things were measured while they were in the hospital. And so each point, each color represents one of the things that were measured, as you can see on the right-hand legend, and each point is a particular measurement of it. So there are things that we can notice, like we can immediately tell exactly when somebody was admitted to the ICU, because when they were admitted to the ICU, all of a sudden we start collecting a lot of information about them that we haven't collected before, and we start collecting information with higher frequency. So we've got to be able to take all of that information that can be sampled at irregular times, and we've got to come up with a prediction system that can tell us whether or not somebody is likely to be septic. Okay, so how is it that we can go about thinking of a prediction for sepsis? So if we think about it, at the end of the day, we're really kind of making this binary prediction, right? This person is septic or not, and we have some probability with which we say that they're septic or not. So really at the end, what we want is a binary classifier, and we want one that runs over time. The problem is that we don't have samples that are nicely spread out, as I showed you on the previous slide, that we can feed into this binary classifier. So what we do is we use a Gaussian process to say we're going to smooth over these irregularly sampled time points, and then use the estimated values at any given time so that we can nicely grid up the space, and we have something nice to be able to feed into our binary classifier. That's kind of the idea behind what we're doing. So we use we start out using like a standard Gaussian process. You can see the equations in the top box, and then we can combine the Gaussian process equations and the binary classifier and do end-to-end learning all at one time. And we can use various tricks in order to make this end-to-end learning of both the Gaussian process and the binary classifier parameters quick, right? So we can use the reparameterization trick of like Kingma and Welling in order to look at switching the gradient and the expectation so that we get faster computation, and other kinds of tricks that we implement here. We look at how many samples are needed to compute an expectation. So if you look at other work that people have done, people will actually only use a single sample to compute an expectation as an approximation. We find that because this is a circumstance in which we have less data and there's higher uncertainty, we do better in computing this expectation with more samples. So in practice, we use something like 10. Okay, so that would be a plug for at the actual computation of uncertainty there. Okay, so we also do a couple of things that relate specifically to our application. So if we think about the Gaussian process mean, it's like you could be not exhibiting a fever right now. You could not be febrile, right? And this could be because you actually don't have a fever because your illness is not making you feverish, right? Or it could be because you've received some kind of fever reducer quite recently. So it's important for us to look at what medications you were given and how long ago you were given those medications. So again, we look at putting that into the mean function of the Gaussian process. And then we also look at a Gaussian process kernel, which smooths not only across a patient, right, so that we have correlated values across time, but then also across different patients, so that even if we don't actually measure a value for a particular vital or something like that for a particular patient, we can look at basically like, are there patients who are like you, and estimate what that person's vital or lab value might be from what other patients who seem like them are experiencing as that particular lab or vital value. And so then the classifier that we use is a recurrent neural network that our Gaussian process feeds into. Okay, so we look at, and I will talk about a bunch of retrospective data in a minute, but we developed this system, and I have here an example case of one particular patient story that I will share with you of using this kind of evaluation technique for whether or not somebody is likely to be septic. Okay, so this is a particular patient who presented themselves to Duke University Hospital. In the graph labeled risk, what we have in the dark black line is the risk that our algorithm thinks pertains to the patient and how likely they are to be septic. The boxes underneath are for a particular lab or vital, so temperature, pulse, respiration rate, etc. And then each of the dots there is a particular pulse, temperature, respiration rate measurement, and there's some interpolation between the two. What is being shown in the risk box in terms of the things that are not the dark black line. So like the blue dots are antibiotics, and they can in general be found in the legend up at the top left. And so this is a patient who needed pulmonary surgery, who came into Duke University Hospital. They were given antibiotics in the run-up to having surgery. And you can see all their labs and their vitals look stable. You can see it's pretty standard to give patients antibiotics in the run-up to surgery, and so here you can see that mirrors this. At the Red Cross, the patient had the surgery, and you can see immediately, basically, that their labs and vitals start to decompensate, right? So the patient starts to decompensate, their temperature goes up, their pulse goes up, their oxygen saturation rate drops, and they're admitted to the ICU. And at this point, our algorithm thinks it's quite likely that they have sepsis. And then a particular lab value is drawn, and that lab value is found to be high, and the patient continues to decompensate And at this point, our algorithm thinks it's almost certain that this patient has sepsis. And the reason why I show this, so the blue dots are then antibiotics that are administered after surgery, and the red vertical line is when the patient is found to be septic. So a sepsis diagnosis goes in like as an ICD code for this particular patient. And then at the purple cross, they actually do a culture and they find the infection. So what I like to point out here is that there's a 17-hour gap between when our algorithm thinks it's likely that this is a sepsis patient and a 36-hour gap until this person is diagnosed with having sepsis. And 17 hours, the reason why we look at the time to antibiotics is because this is a reflection of when a clinician thinks that this person is septic and starts giving them antibiotics in an attempt to treat the sepsis, even if it takes longer until the ICD code diagnosis. Okay, so the reason why I show you this is because 17 hours or 36 hours is a very long time in the life of a sepsis patient. And we could potentially do a lot of good for that particular patient if we could diagnose earlier, even 17 hours or 36 hours earlier. And so that's what we aim to do. So we look at retrospective data. So we look at 18 months, 32,000 inpatient encounters for patients, and we use 14,000 for testing. So it's 6 months after that. We look at a bunch of longitudinal variables based on covariates and then medication classes. So remember, to set the mean of the guessing process function, we needed to know how long it's been since the person had a particular medication, and those were grouped by clinicians. And we look at how different methods perform with respect to this data. So MGP-RNN is, of course, our method, but then we can look at raw RNNs or logistic regression or the new score. And we see that we're performing significantly better if we look at things like area under the RSC curve. We have a lot more comparisons than this, but this is just a plot that I'm choosing to show you on the left. We compare to like a lot of things. And then if you look at the plot on the right, you see that the number of false alarms can vary depending on where you choose to exist on this RSC curve. And so we were very conscious of the fact that with the new score, it was alerting so much that the nurses who were taking care of patients were just ignoring it. And we didn't want that to happen with the methodology that we deployed. And so one of the things we did is we talked a lot to our clinical collaborators about where on this curve we want to lie in terms of the number of false alarms that we thought the medical staff at our hospital could handle, and what the trade-off looked like with respect to diagnosing somebody with sepsis. And the point at which the discussion with the clinicians led to our method performing at was 0.8 sensitivity. So that's basically one false alarm per one true positive. And we use this methodology in order to create a system that rapid response team nurses could use and monitor, and has now been run on over 100,000 patients coming into Duke University emergency department. And what you see with the sepsis watch system, so again, it's the rapid response team, the RRT nurses who are monitoring this for everybody in the emergency department. And this is not real data here because that would be a HIPAA violation. So what you see is each person comes into the ED, you get some amount of demographic information, you see what the prediction is in terms of our methodology, in terms of how likely you are to be septic, and what kinds of monitoring you want to do. And then eventually, if you think that the person is likely to be septic and you want to start treating them, you can put them in the treatment category, where you start running them through. So in the US, we have something called treatment bundles for people with sepsis. So this means that there's a prescribed bundle by the government where you have to treat somebody, say like with IV fluids every 3 hours and with vasopressors every 6 hours, and you need to make sure that you're on top of this. Now, one would think that hospitals would be good at being on top of this, right? giving people IV fluids every 3 hours, giving people antibiotics every 6 hours. But what we find looking at the Medicare Medicaid system is that actually hospitals are not very good at being compliant with the treatment bundles. And so Duke's baseline rate of being compliant was about 50%. And by having this system that had nurses analyzing it, we could use the system to remind people to be compliant with the bundle. And we were able to raise our bundle compliance rate at Duke University Hospital quite a lot. So black is people definitely diagnosed with sepsis, red is people suspected of having sepsis. And we raised those numbers to 67% compliant with the sepsis bundle and 56% compliant with the sepsis bundle. Okay, and so now I'm going to talk a little bit about the work, which is really social work that was done by Madeline after Madeline Ellish. This is who I'm fortunate to have as a collaborator colleague of mine at Google. But she did at Duke some analysis of what the actual workflow response was to this kind of system being deployed, again, in the ED of Duke University Hospital. And she had many interviews with many people and did a lot of observation of clinical behavior and organizational meeting behavior. Okay, so her findings were that that this system managed to really destabilize and disrupt in unanticipated ways, unanticipated at least by us, the organizational norms of how the hospital was running. And more surprising was how these destabilizations and disruptions were rectified. And that trust and accountability were fostered through methods and through ways that didn't include interpretability. So the solutions here were really not algorithmic solutions. The solutions here in part were solutions that people came up with, particularly the RRT nurses who had to deal with information coming off of the sepsis algorithm. Sorry, lost my train of thought. That had to had to deal with some of the information coming out of Sepsis Watch and all of the in-person interactions in the hospital ED. And so what you would see was things like power hierarchies were being disrupted, and it's like how did they deal with this? They said things like, it used to be that the doctor would tell the nurses what to do, and they had some specific medical judgment, but now medical judgment was in part being made by a computer, and so information was going the other way. It was flowing from the RRT nurses to the doctor being like, hey, we're actually getting this reading coming off of our septic system. The RRT nurses also had to do a lot of emotional labor to talk about this risk score in the way that some of the ED doctors wouldn't reject. So, they'd have their phone calls with the doctors and they'd be like, we're going to start off this phone call asking just like, how are you doing? And so I have some kind of indication about how the call is going to go. And then also our RT nurses put in extra work in the form of extra chart reviews to back up what the automated algorithm was saying, right? So it's like, I see also these things coming in off of their chart that would back up the decision that was, or the concern that was being raised here. And so the repair work being performed by the RT nurses could be effective and empowering because the professional discretion and expertise of the RT nurses was supported and not undermined by the team that's developed Sepsis Watch. And this is really important, really, really important, because your workflow is being disrupted, that you have to respect people's expertise and shifting methods of communication within a hospital setting. Okay, so now I will ask, how am I doing on time?
You have another 3 or 4 minutes.
Okay, I will try to, with apologies, race through some of this stuff in 3 or 4 minutes. That would basically concluded everything that I had to say about the sepsis system. And I think that really the main point I wanted to make there was that there are a lot of interpersonal things that we really need to take into account. Not every single thing can be solved by an algorithm or by an automated methodology. Okay, so basically what I wanted to say about multiple sclerosis was that this is really along different lines. This is like looking at people's health and looking at people's health outside of clinic and understanding that it's really complicated and that to date we've really only had information that we've been able to take in about people's health through the time in which they're in the hospital or in a clinic. And what we'd really like to do is to be able to get information about people's health when they're not in the hospital or not in clinic, because hopefully people don't actually live most of their lives in the hospital or in clinic. And so the problem is that somebody's chronic disease could be incredibly complicated, as displayed by this picture here. But when you look at what the clinician is seeing, it's really only a small fraction of this. So they see maybe, okay, so I don't know how all of your doctor visits go, but basically mine go, I walk in, my doctor is like, how are you doing, Catherine? And I'm like, fine. And basically it's like the clinician has to get from that every single patient walking in and saying, fine, right, to actually figuring out what's going on and what this picture actually looks like in the 15 minutes that they have for their patient encounter. And so what we wanted to do was we wanted to develop extra methodology to help them do this. And so what we developed was an iPhone app, which we called MS Mosaic. And I developed this in collaboration with a neuroimmunologist at Duke University. And I should say that you should consider this talk a real plug for collaboration between computational people and clinical people, because it's really with the meeting of these two things that you have useful, helpful, automated methodology coming out. And so this MS Mosaic app looked at surveys, and it looked at activity information that you could get off of an activity tracker and other tasks that you could complete on your phone in order to try to get data on people when they're not in a clinic setting. And we found that you could use this data. And so now this is just some longitudinal predictions that were made by some of the master students that I was working with. We found that you could use this data in order to try to do things like predict what symptoms their patients are likely to have at some point out into the future. Here we look at 5 days to 30 days. And we found with a lot of the symptoms that you might expect for this particular chronic disease, we were able to do a much better job than baseline, which was just if they experienced this symptom in the past. We were able to do a much better job at predicting whether or not somebody was likely to have a symptom going on into the future. And we also looked at other things that I'm not showing you here, like symptom subtyping. Does this particular chronic disease actually have different subcategories of patients? And what do those look like? And then this is really just to show you, this was a survey that I gave out in Lee's clinic. So this is in the neurology clinic at Duke University Hospital to multiple sclerosis patients, showing that a lot of their patients own a smartphone, but a lot more own, maybe unsurprisingly, Android phones as opposed to iOS phones. And if you remember, what I talked about with our app is that it was iOS only. And so going forward, we really want to expand the pool of people who this kind of work can touch. And we also want to look at things like, is data coming in the form that people want to give us data? Because dropout rates for these kinds of studies or this kind of method for collecting data, dropout rates are really high. You don't want to take people's cognitive attention more than necessary. And so it would be good to look at in what form do people with chronic disease actually want to give us data that we think can be useful. And so basically our overall idea for the future going forward is that there's a whole group of people who have a particular chronic disease. We give them the method for communicating what their disease is like on a day-to-day basis to their clinician. They can get feedback from their clinician about what their care plan might be, even dynamically. We want to empower them more. We want to engage them with their community more. We want to enhance their care more. But then other people can also have access to this data, potentially like the government or other health systems, in order to improve the life of people with this particular chronic disease. Okay, is my time up?
Yeah, I think we are a little bit over, so.
Yeah, sorry, I'll stop there. I also had some infectious disease stuff that I could talk to you about, but if anybody's interested, you can contact me.
I am super interested, Catherine, and if you would stick around for Q&A after the next
of course.
talk, that would be wonderful. Just the logistics of trying to do any kind of clinical work with computational work is really a big mystery to me.
Yeah, no, thank you so much.
Awesome. Thank you very much for this wonderful talk. It was really great to learn that a system built was actually deployed, which is sounds like a really large hurdle of putting it out in the real world, like you said, disrupting norms and things that people are so used to. So I'd certainly be interested in learning more about that. And maybe after the next speaker, we can get into it.
Yeah, no, fantastic. And yeah, it was really a collaborative effort, and I have lots and lots of really amazing colleagues who were involved in that process and continue to be involved in that process.
Wonderful. All right, so our last speaker, the third speaker for today is Dr. Matt Bean. Matt is an assistant professor in the technology management program here at UCSB and is a digital fellow at Stanford and MIT. Professor Bean's talk's titled Shadow Learning, Building Robotic Surgical Skill When Approved Means Fail. So,
great. Well, thank you very much, Misha. And it's wonderful to meet everybody here and very cool to learn about everybody's work. I'm going to start at robotic surgery, which is a sort of a germ for a research program that began in about 2014 and end with some work that's inspired by this original study. Let's see if I can get Prezi going here. So to begin, this is the most graphic image I am going to show for those of you who may be concerned, but the basic question that began my research program in this domain was what happens as we move from a mode of working that allows trainees to build capability as they participate with experts in the work in a highly interactive sort of way, to more digitally and computationally mediated forms of working, like robotic surgery on the right-hand side here. How do they learn? How do they build capability? That's the sort of core question. And here's a robotic surgeon from my study. She says, say you were in Upper Maine or something, and you needed to do a hysterectomy and you didn't have a partner to operate with. You could use the robot and get your surgery done. So the robot allows people to operate without other surgeons in the room. That's the bottom line. This is a general finding that has shown up across a number of contexts now, that in general, and this is, I think, to the good, we, in the case of robotics, we get experts' capability deployed at greater scale and to greater effect through the deployment of these technologies. And at the same time, part of the way you achieve that is to cut trainees out of the work. And that's certainly what happened in the case of robotic surgery that I wanted to focus on. So trainees are slower and they make more mistakes. And so that's one of the consistent ways that you can get more efficiency from a new technology, is just drive them out of the work essentially, or make them optional. So just a quick highlight to the end here. I've since gone beyond surgery to find this pattern across numerous kinds of technologies, in what I call intelligent technologies, in various forms of work. I report on those in my TED Talk and in Harvard Business Review piece. And I'm going to talk at the very end, time permitting, about a system that I'm building with collaborators that is now beyond usability testing into a deployment that tries to remediate some of the challenges that I'm going to illuminate here in a moment. So the research question here is a bit of a mouthful, but it has to do with the body of work about how we learn at work while working that was accepted up and until recently. So given efficiency pressures and this sort of reconfiguration of work through technologies, in fact, some of the ways that we've seen already in previous talks, that if they reconfigure trainees sort of out of the work to some extent, how do they learn? Basically, this previous body of work on learning in the midst of work has named that phenomenon as legitimate peripheral participation. There's that mouthful. This is quite highly cited work across a lot of fields now. And the basic premise there, and this is induced across a lot of empirical study, is that we build the bulk of our valuable work-related capability through these semi-structured interactions with people with more expertise, as that expert is actually working on a challenging real-world problem. And that we are granted via a role, say apprentice is a typical title for that kind of role, or in my case, medical resident. You're granted access to helping in the work, and by helping, you learn. That accounted for how people learned in open surgery, not robotic. And I had developed new theory to account for that. The way that I did that, and this is a little bit like Madeline Ellish's work that we just heard about, is I did a couple years of ethnographic study comparing how people learned how to do open surgery and robotic surgery across 5 hospitals. So in 5 top-tier teaching hospitals, I was in the operating room most days of the week with a laptop on a movable stand, typing as fast as I could about what was being said and done in that operating room, and then also following those residents around in their normal daily work, interviewing people who are participating in that work. And then, given that there were very few medical residents who seemed to be building very high quality robotic capability, I deliberately tried to go find more of them at other institutions. So for the second chunk of the study, I ended up getting connected with 13 more top tier institutions. This is roughly about 70% of the top tier institutions, like very top tier in the US. And asked to be connected with medical residents in each location, one of whom, in the eyes of a senior surgeon, had developed exceptional skill with the robot, and one of whom who was just merely average. But I was blinded to that fact before I began those interviews. So I used the same protocol with everybody, just asking them, how did you learn how to deal with this robot? How have you built skill? And I was unblinded to their status after I collected my data. In the first year, however, I only found 3 individuals out of these 5 institutions who seemed to develop serious robotic capability. And they all seemed to do it in the same way without communicating with one another. And all of those methods were counter-normative. So I turned to theories of deviance to try to help explain this. And by counter-normative, I mean either breaking a policy or a strong norm. And this was necessary because, just logically, if the normal way of learning your surgical skill in this case is through an approved method, and that doesn't work, then you have to learn through a non-approved or illegitimate method. And that has to be quite durable. You have to learn over time. This takes years to build this capability, so it has to be tolerated. So to get at specifically how this showed up, I want to quickly ground you in robotic surgery. On your left on this image, you have 2 surgical consoles that control the same set of end effectors. This is the robot, as it's referred to, is the device over in the right-hand side of the image, has a number of arms that control small keyhole instruments that go through small incisions into an inflated space inside the body with CO2. The senior surgeon operating on the far left here, for example, controls this robot and can digitally delegate control of that robot to the resident sitting in what's known as a trainee console. But that delegation is neither required nor by policy or rule or norm. It's entirely optional. Just so you can imagine what's happening as I describe the process here. So rewind now to open surgery, traditional surgery. We're working side by side in the operating room. This traditional OJL, or on-the-job learning, or legitimate peripheral participation, I'm going to call it OJL from here on in, worked well in open surgery. It was hard to see when a resident was making a mistake, even for the surgeon operating right next to them. But fixing those errors was pretty easy, and resident help was needed to accomplish the work. and I could delegate to that person flexibly and privately. So here you have this resident saying there's more going on in open surgery than in robotic. It's not apparent to everyone in the room, and it's easier for the attending to also move in a different direction if you're not doing something right. They can take, instead of a 50-50, it can be a 75-25 sort of thing, basically. Instead of letting you get into the appropriate plane of a dissection, they're getting into the planes of dissection and basically just cutting. But you still feel like you're part of the procedure and the attention is not pointed in a negative way. This broke down in robotic surgery. So rewind to that image I just showed you. It was very easy to see when a trainee was making a mistake. It's on large LCD screens all over the operating room, and recovering was really hard from a mistake. So a resident says, in open surgery, if you put a hole in the iliac vein, yeah, it's a big problem, but you can put your finger there, compose yourself, and get control. If you cause that in a robotic procedure, the patient could hemorrhage before you regain visualization. This is because blood is hitting the camera, basically. If surgeons think they can do it by themselves safely, they're not going to want to take that risk. In other words, they won't delegate. Another thing that blocked learning is not just not being willing to delegate via this tool, but when I do delegate to you, I helicopter teach you because I can digitally micromanage your work as a resident. So here's an example. This attending, this is me typing at the speed of conversation in an operating room. An attending is at the primary console. Do you think I was happy about that or no? And the resident says, no. The attending says, yeah, because you're taking your bipod, which is a cautery instrument, and ramming it into the bowel. If you're going to do some blunt dissection, pretend like you've done it before. Stop doing that. Take a break. And then they digitally take control just with the press of a button. I say, don't do that, you do it. Don't do that, you do it. I don't know how I'm not supposed to get frustrated. This isn't a platter. No more using this hand for anything except for pulling things down. And then he gives control back. This in the 5 to 7 minutes that a resident got to operate, this is the constant tenor of the dialogue. So you can imagine that it became difficult to learn. In fact, across all my field notes, across all of my observations, and then in interviews, it seemed pretty clear that minimally there was a 10, but in most cases, 20-fold reduction in participation for that resident in the work, such that they could develop their capacity by doing. And even when they did get to participate, that value is constrained. So this is a chair of the urology department at one of these top tier institutions who describes the implications of this. He says, it has the opposite effect, and he's talking about learning. He's talking about 2 surgeons here trained in top programs that teach robotic surgery, and they suck now. I mean, these guys can't do it. They haven't had any experience doing it. They watched it happen. Watching a movie doesn't make you an actor, you know what I'm saying? In addition, their exposure to open surgery has been altered by the presence of robotic surgery. The younger guys become deficient because they watched a lot and do nothing on the robot, and they're becoming deficient in open because most surgery is going robotic and less is open. So that's shit and bad luck. I mean, you stink in robotic and now you're stinking in open because you're not doing enough. So most residents at all the institutions that I covered did not acquire sufficient robotic skill by the end of their residency. About 1 in 8 was assessed by senior surgeons as being competent. But demand for this service and this technology is extremely high. So all of these graduates were legally empowered to operate using the tool. And they're learning in prior techniques, which are the very techniques required to correct an emergency in robotic surgery, by the way, also suffered. So there was a rare few who managed to learn in spite of all the pressures I just cited. I'm going to focus there for the rest of the talk. Here's this senior robotic surgeon referring to one of them, saying, we have a 4th-year resident here now who happened to do research time in a robotics lab before she started residency. So she's like way on this side of the curve. I can already tell she's great. She's better than most chiefs. So, but she had spent significant amount of her life, like 1 to 2 years in the robot lab at this hospital doing research. So it's like cheating, you know? The key point of the cheating thing within surgery is key here. Doing research on a technology is premature at this phase of a person's education. There's this sort of norm violation characteristic that shows up in all of these methods of learning that I'm going to highlight here. Those who built significant robotic capability during their residencies independently reported engaging in 3 interdependent practices roughly in sequence. And they differed in 4 key ways. So first, obviously, they ran counter to norms. in some cases policy, and I think even in some cases the law. They were enacted opportunistically and in relative isolation. Traditionally, we learn in cohorts and we learn together. And they got you the competence that you needed with this tool such that the first time you showed up in the operating room, you looked like you knew what you were doing, such that the senior surgeon would be willing to let you operate more. Normally, in traditional OJL, it's the other way around. You are granted access such that you may now build competence, but in very safe tasks. So these three practices, I'm not going to cover them all in great detail, but the first of them is premature specialization. And this is getting exposure to some advanced technique at the expense of what should be a generalist education. This is the research example that I cited earlier. So all of these successful residents in some way managed to get, say, during medical school or even before medical school, deep exposure to robotic surgery at the expense of time, say, with general anatomy course or something like that. Abstract rehearsal and undersupervised struggle, I'll walk you through now. I'll give you some detail. So here's a resident who did engage in abstract rehearsal. They said, you can watch videos on YouTube. YouTube figured prominently. The guys that operated there had a video. So I watched that video. I probably watched it, I don't know, 200 times for an hour long video. A lot of hours watching it. It lets you see his moves and where his hands were going and how he did things and how he was retracting things. So all surgical residents watched video. They all used a simulator, every single one of them. Those who developed significant and rapidly developed significant surgical capability, it was maybe 2 orders of magnitude more time on these tasks and much more fine-grained use of their time. So first, they practiced their basic skills in simulation. They spent a lot of time with the simulator. And they analyzed recordings for familiarity, like before they got involved in the procedures. And then right before they got involved in a particular procedure, they would go back and do targeted review. All of this was counter-normative in 2 ways. One, senior surgeons routinely referred to video as being an inappropriate, wholly inappropriate means of learning surgery. You may remember that quote from the chief earlier saying, watching movies doesn't make you an actor, right? The way one ought to learn surgery is by doing it in the operating room. This is the standard sort of accepted procedure. The other way it's counter-normative is that engaging in all of these activities it takes time away from other critical activities during residency. Residency is a zero-sum game. You're working between, say, 90 and 120 hours a week. And if you're doing any of these things, you're taking time away from family, losing sleep, taking time away from patients, and so on. Undersupervised struggle is engaging at close to the edge of your capability, dealing with challenging problems with limited or no expert supervision. So I'll give you a couple examples here. If you happen to work for a superstar robotic surgeon, you ended up getting a lot of rope to play with that you shouldn't by policy. So this resident says, you would do simple parts of the procedure first. Our goal was to do that portion of the procedure independent, meaning no one else was in the room. You start the case, you dock the robot, and you get to that point, and then you call the boss or the attending surgeon, and the boss finishes it off. 4th year, we did more. By the end of it, you're doing it all yourself. I still don't know whether this is against the law, but it's certainly contrary to policy. There should always be an attending surgeon in the room in private hospitals. In other cases, you might end up working with a lower skill expert who actually looks to you, even though you're as a bit of an expert. Here's a resident who said, what's really influenced my training is by having other attendings within our own institution that are not as experienced or proficient as he, their mentor, is. The attending that's on that service, I think, probably feels that I do the case as well as he can. So he'll allow me to do much, much more. And he'll actually defer to me a lot of the times and say, oh, well, what does X do? What do you want to do? So these advanced residents would find ways to get engaged in the work such that they were struggling near the edge of their capability with limited expertise around. So you can, I hope, see why that one was in particular a little shocking to learn about, but certainly counter-normative. So the key here in terms of consequences, this worked, this method of shadow learning. So these 3 practices all ran counter to norms, but those who engaged in them repeatedly ended up building significant robotic surgical skill. And this was the only way to do that. Anyone who did not engage in these practices across all 18 hospitals that I covered did not build appreciable robotic capability. And there were some second order consequences or unintended side effects of this. First off, if you were a successful shadow learner, you became hyper specialized. You are a very, very good robotic surgeon and don't know as much, can't do as much outside of that domain. And yet most of those people would land in generalist positions where not just robotic surgery was on your plate, but vasectomies or other kinds of procedures that don't involve the robot, and you still have to do them. Your learning also as a shadow learner comes at the expense of the others in your cohort. So if I happen to build that capability, the people around me would get less access to the console and to operating because I was given more. Sort of a zero-sum game. And the community of practice itself, surgery, didn't much learn about this new way of learning that was required for robotic surgery because it was done in isolation and in quiet pockets. It has only recently become clear to the field that video is an important way of learning, for example. And I started my study in 2014. So to move on to subsequent work. First piece of work that I did following this study was to test, well, in what ways is this showing up in other classes of work, other professions, given other technologies? This is a very quite unique context. So I got raw data from 23 other individuals who had completed comparable studies to the one I just described, at least a year's worth of ethnographic data. Madeline Ellis at Google is a good example of this kind of researcher who had done research involving various technologies, AI, robotics, sometimes a combination. And I found by looking at their raw data that the same pattern was happening. In other words, that juniors workers were getting cut out of the work in some way. And that shadow learning was evident in all of those cases. And so I wrote this up as a Harvard Business Review article and spoke about it on the TED stage to offer guidance for technologists, managers, and users who are contending with this problem. How might you design technology differently? How might you buy it and implement it differently? How might you use it differently to minimize some of these challenges? And most recently, I've, in the last, say, year and a half, started a project to build an infrastructure for digital apprenticeship that sort of follows in the footsteps or sort of takes a cue from these residents who focused in very intensive and particular ways on using video review to build capability. And so we looked at their practices and have taken best-in-class HCI research in collaboration with the world's leading center on video learning for robotic surgery to develop a system that involves crowdsourced and automated annotation of surgical video, such that remote distributed users can build their surgical capability in similar ways to these shadow learners. Usability testing is complete there, and we're just beginning a study to actually see what effect this might have on clinical outcomes, on progression for residents and their skill, and so on. And so that's the sort of practical end of this work, and I look forward to it continuing. And thank you again for this opportunity to participate in this really fascinating conversation.
Awesome. Thank you, Matt. That was like a whole nother world of what's happening when it comes to learning in the workplace, trying to learn difficult skills where you don't really have an option of trying to do them outside of that workplace. And it's really cool to see a video. I was kind of curious about what kind of simulators used. And I asked because I do work in virtual reality, and I know that there are some startups in that space trying to do it for medical domain training. And I was wondering if that was an option for, especially like you said, social learning and things like that.
Yes, simulators have been an option since day one. So 2003, 2004, depending on how you count with these systems. The challenge with that and most other technologies for learning is that you need to physically go to a different space to sit down at a simulator to use it, or to go to the resident break room. And that comes at the expense of some task that you need to go tend to right now. So tending to a patient, completing a surgery and so on. And right now, the resident training programs do not have discretionary time for training built into them. It's a very odd situation in that there are many professions like pro athletes who spend the bulk of their time training and a very little amount of time playing. This is the opposite. And so that just runs into this structural impediment where systems have gotten very good and they are being commercialized. They're hitting this cultural brick wall, which has this sort of inverted time allocation in terms of work versus training.
That sounds like more changes needed than just making training in people's attitudes. It's the system there that.
Yeah.
Okay. We have a related question from Mary Haggerty, who's asking, or who's saying, I observed some surgical training at UCSF years ago, and they practiced laparoscopic on animals, specifically pigs. And she's wondering if it's ever used in teaching people robotic surgery.
Absolutely, it's mandatory. The mandatory curriculum is wildly insufficient for building capability that is reliable under pressure. This is pretty widely accepted. So for example, the average requirement for using a simulator is 4 hours a year for a surgical resident across all hospitals, top tier hospitals, by the way, in the US. And you generally have to do a pig lab. That's generally required, especially for a senior surgeon, not always for a resident, but those tend to last a day and then you're done and you're certified to use the system. The research on skill decay, given lack of utilization, is extremely clear on this front. That is just maybe 2 orders of magnitude less time than you would need, but certainly 1. So yes, all of those things are available. They are in fact required by a number of institutions. It's just the volume and the diversity of that training is just insufficient.
Do you think things haven't just caught up to it? Like robotic surgery spread and hospitals started using it at a much higher rate than the entire system caught up to providing surgeons who are capable of doing that surgery, and they're still trying to play catch up, or they just haven't figured it out yet?
That's true to a degree, although I began my study in 2014 and this technology had already been in the field since 2003. So the field had quite a long time to adapt on the one hand. Another confounding factor is that even best in class studies now that look at, say, the relationship between pedigree or training and surgical outcomes don't do a good job controlling for surgeon expertise or volume of procedures. So superstars of the kind that I found in my data set skew the data in terms of the efficacy of this method compared to the bulk of the population. I think the minute we start controlling for that variable in studies of training and outcomes, we're going to see some stark new effects that have persisted. Yes, of course, there are new technologies out there, and institutions are changing slowly to address this problem, but slowly is the operative term.
Do you think then, given what you learned, that video is a good alternative, not alternative, a good additive way of doing this, and that's sort of what the next initiative, the digital
apprenticeship.
Yeah, you're looking at.
Yeah, so that is just one of many potential directions. It's just, in general, I'm a fan of developing technologies that users are already cobbling together for themselves. That's a good sign that they will use it and use it to good effect. In my case, anyway, I had the top skilled residents independently scouring YouTube and reviewing videos very carefully, and so. But there are numerous other potential directions, technological trajectories. Augmented reality is a fantastic example of ways of impedance matching these new technologies to the cultural realities that we're trying to introduce them in, so such that you get actual uptake and change. But yes, so that's my next potential direction, sort of crowdsourced with automated labeling of video as a way to build capability that allows a resident to show up in the operating room and look like they know what they're seeing and know how to help.
So then there's the opposite side of it, or the other side, I should say, of labeling video is motivation to generate more and different types of video, maybe different perspectives. There's cameras on the robot heads and all the arms that it has and all those things instead of just, I mean, I don't really know what the scope of the scale of videos is right now out there. So I'm wondering both things then could be improved.
Yes, absolutely. And they are. Cameras are increasingly capable and inexpensive, and that's fantastic. Privacy is an issue in this particular context. You have to make sure to abstract away personally identifiable information. That takes some savvy and some techniques, but yes, so, and there's now video of the operating room itself. So outside of, I mean, one kind of valuable video is the video inside the patient and what the surgeon is doing with the system. The other kind of video that's valuable is of all of the activity in the operating room. There's an entire team required to make this system effective now, whereas before, 2 people would operate side by side and nobody else really knew what they were doing. So video of that entire operating theater could also become part of that data set, absolutely.
All right, sounds wonderful. All right, on that note, I think we have 25-30 minutes until noon, so let's open up the whole space to Q&A for all the panelists, and I'd be happy to ask any questions that come in as they do for Catherine, for Tim, and for Matt. Okay, I guess as we're waiting for questions, and since I didn't get a chance to ask Catherine anything after her talk, I was wondering, Catherine, how do you even get started? Well, first off, data sets, when it comes to medical data sets, is not that easy to get hold of. How do you even get started with the process of, collaborating and getting access to this data? Because it's got to be, I'm at UCSB and we don't have a med school. So you think we're totally out of the game of trying to do this, or we can still try to do some work in the clinical side of things and partner with folks.
Yeah, and maybe other people here can comment on this a bit more. I don't know. So most of the data that I had access to was as faculty at Duke University and existed within Duke University Hospital. So electronic health record data that is from your institution is the easiest to get a hold of. Obviously, I really now work at Google, and similarly, there's no med school at Google, obviously, and I would classify getting a hold of data as very difficult. And so I could say a lot about this, right? So I have colleagues, other places like at Princeton that doesn't have a hospital that manages to collaborate with like UPenn that does. So there are ways around it. I think making the leap into industry actually makes things more complicated. And so I would kind of my line, though I don't think other people at the company necessarily agree with me, but kind of my line has been like, I actually don't think things relating to EHR data and hospitals are really the place that Google can have the most impact. And that's kind of why I talked about some of the multiple sclerosis stuff and some of the like Android, like at home, getting a sense of like what your health status is like at home context. I think that's where companies like Google or like Apple have a lot more to add to this situation, and then can potentially release things direct to the patient as opposed to going through the hospital and the clinician, because I think that's really difficult.
Okay, well, thank you. That's kind of the impression I have, and we've attempted once working with clinicians at a different hospital. And while there was a lot of enthusiasm when we met a bunch of times, it seems like it kind of fizzles out because the logistics of trying to integrate something new into an existing system just seems too overwhelming. And certainly is the other side of the problem, right? It's what do you do after the data set? You build a system and now you want to integrate it. But then there's this whole, as the ethnographic study showed, that there are challenges in doing that, and not everyone is open-minded to doing it.
Yeah, I mean, I think it takes really tight collaborations with like clinicians, and then social science probably exists at all universities, but or most that I can think of, and so having like this really robust team makes a lot of sense. But I'm I'm also in the process of trying to do that, right, from Google to other hospitals, and so I will similarly keep you updated on how that's going.
That would be great. Yeah, thank you. All right, we have a question for Matt, and the question says, do you think there's an issue of not getting enough appropriate training? I mean, certainly sounds scary, right? We got people out there who are not really well versed in using these robots. Or is there something fundamental about the two techniques, regular surgery and robotic surgery, conflicting with each other? Do we need separate experts for each surgery type, robotic and non-robotic?
Yeah, so yes to both. The second one I'll deal with directly. The Harvard Business Review article that I wrote puts a very fine point on this. One of the things that's a very consistent finding across every study I've been able to lay my hands on is something I'm calling methodological overload, which is you get a new tool that is sufficiently different from the previous method, such that you building capability in one, there's not enough overlap with the capability in the other, such that you can just sort of get, sort of fudge your way forward, so to speak, with a new tool. That was true with respect to, say, the difference between certain open surgical techniques and in other disciplines, other certain modes of diffusing a bomb or negotiating a contract. So if you end up with methodological overload, which is seems increasingly common, you try to specialize in both because you are expected to be an expert, and you therefore fail in both. You end up with insufficient capability in both domains. It takes the sort of preemptive effort that I have now found in a number of contexts to get enough of a run at one of those two capabilities, such that when you arrive at being expected to specialize in both, you are practically capable in one already, such that it's still a sort of a one-time game. So yes, training protocols, I think, need to be revised across numerous contexts and with numerous technologies. And we also need tools that perhaps sort of more formal specializations. In Europe, they're actually starting to create physician specialties that are sort of procedure specific, and that you are not expected to be a generalist any longer. There are different degrees even now for that, and different levels of compensation. But the US so far has resisted that kind of thing. I'm not advocating for it. I just, lots of degrees of freedom. It's just all those kinds of changes are hard.
Thank you. The next question is for Tim. It says, the prospect of having the same company designing digital assistants and having an interest in selling specific products seems problematic, specifically for healthcare. What do you think are the solutions to this conflict of interest?
That's a great question. I don't know. I hate to say the word regulation. I mean, I don't see how else we can enforce safety standards on this community without some kind of regulatory action. I don't think self-policing is going to work.
Do you think there's any in the works right now, or this is? I mean, I know that there's already regulations sort of in the work for deepfakes and other newer media elements, but I was wondering.
I don't know of any. Maybe someone else does, but
yeah, so there's definitely some regulation, and I'm embarrassingly don't know the details, but there's definitely some regulation that's being proposed in Europe. I know that there has been regulation that's come in around sort of like improving ethical standards just in general, both across the US and Europe, improving ethical standards in healthcare frameworks. But what I was going to say was also that, like, in terms of internal policing, right? It's something being at Google. I know that's something that Google is kind of sort of trying to do, right? And that idealistically they would like to do that, right? And so it's like, if you look at things like Meg's model cards, or like Timnit's like data sheets, there are things that I personally am trying to use to develop sort of like procedural ethics frameworks for a lot of the healthcare space. Google, there's probably a limited amount like recorded I can say, but they are definitely, they do talk about wanting to have this happen internally, and so they do kind of back this effort. At the same time, look at what's happened to Megan Timney, right? And so I think that they would be big supporters of, and I would definitely be very understanding of wanting external regulation also in this space, and how this space moves forwards, whether it's like non-governmental organizations coming in and doing some external monitoring, or governmental agencies having more traction. It's probably going to be a combination, because my guess is that like nobody's really going to do it well, right? And what you want are like multiple different bodies trying to do it. Okay, sorry.
Yeah, maybe it's going to take a few well-publicized cases, right, of actual harm or safety problems to spur some action.
Yeah, I hope not, because like I think you're right, but I hope not, because like I feel like the chances that I'm involved in that are like reasonable.
I guess just going off of that response, maybe all three panelists, and I'm wondering what, as researchers, as academics, are potential responsibilities when it comes to dealing or talking about ethics for things that we're building. Maybe it's new models, new algorithms, new applications, because these are still academic projects, right? We're not putting them out in the real world. Well, sepsis is out in the real world, but I'm just wondering what kinds of things can we do, or how we write our research up, how we release source code. What are the things that we can actually do to help push this dialogue forward, and eventually maybe someday get to some regulations?
Well, I should say that, sorry.
No, go ahead.
I mean, this is what motivated this whole line of research for me, is basically, policing ourselves, right? To try and demonstrate what are the potential harm or the potential bad things that can happen if you go down this path. So that's one thing we can do, is research to demonstrate problems.
Yeah, and I absolutely agreed. And from my perspective, at least lately, on two projects, one of which I mentioned here that's now out in the field and it's deployed, and another that's in development, setting a standard for what superb looks like is just as important, I think. And so, that in one case, for example, meant pulling together an ethics review board for a project that went above and beyond the requirements of the IRB for our institution, for example. It involves workers in warehouses. This is another domain of research for me. And the ways that they have traditionally encountered technologies in that workplace. And we just tried to invert that, because in general, they get the short end of the stick. But it was no longer the IRB for our institution that we were sort of setting as our top bar. It was the best board of ethicists that we could pull together across numerous institutions whose explicit research focus is on trying to create human-centered, artificially intelligent systems that amplify, extend, and build on human capability, not just fail to harm humans. That's, to me, a more interesting and much more complex standard to hold ourselves to, and requires innovation on all of our parts. No one has that figured out. And so it should hurt to invent the ethical standards for our projects. We should, at least I'm spending a lot of time trying to trying to pull together that expertise and those voices, and then to publish about that.
What do you guys think about, in the interest of making everything open and whatever we're doing, we all tend to release source code and people can replicate what we're building and also validate what's happening, but you really can't control what you're putting out there, how it's going to be used, right? And so it almost sounds like there are these conflicting notions here of wanting to be open, right? Everybody should have access to your research and what you're doing, and then you really can't control what they're using it for, right? And I use the example of deepfakes because they are and have been used for a great amount of harm to individuals, impacting people's privacy and lots of issues. coming out of that space. And so I was just curious what you guys thought about that. So.
How do you keep someone from using your hammer for something you didn't intend? I don't know.
Right. I know it's a hard one. And I'm mostly asking about, some about release. Yeah, I actually don't have an answer. I don't know. It is a hard one because you do want to release your code and you want to release your models. Although people can try to build cool things on top of that or even test it out. But some of those things can be really, really harmful. And I don't know how to do this.
I think I'll come down firmly on the side of like things should be open, right? And then the problem of like misusing something really lies with the person who's misusing. It's like, let's go back and put like responsibility on people again, right? Like, I think the problem with the misuse of something is really on the person who's misusing it. And there are things like regulation, right, which should play into keeping people from doing that.
Right, regulations are just a little bit behind in terms of catching up to how quickly we're moving ahead when it comes to building newer technologies.
And medical school training, right? So like one of the questions I was actually interested in asking Matt is like pragmatic tips for how you might affect med school education, because particularly at Duke, I had all of these conversations with people around like, can we please modernize med school training a little bit?
Yeah.
Please, please, please. And I was told like, no, this is an institution and you can't change it.
Right. And if it doesn't go all the way back to Hippocrates, it's not appropriate or effective. So the easy one is allow for the things that users are already having to do for themselves at great risk and expense in order to build capability in spite of that system. So a good example of that in med school is the ones who got ahead were cutting class and skipping assignments in order to go to the robotics lab and practice. And so what do you allow for? Premature specialization. Pick a specialization and rearrange your curriculum. Give me 7% of that person's time and allow them to invest it in whatever they want. It's not Google's 20% time. How about 4%? Anything. And I think if you get a few leading institutions, you have to go to the ones that are viewed as the ivory tower at the top of the ivory tower to show that, in fact, our residents come out just fine. Our medical students come out just fine. And by the way, they are prematurely specialized in the domain that they are already interested in. Then people will follow. So you start at the sort of the place where it's hardest to make change and yet is most visible, perhaps. But boy, I mean, I haven't done research to show whether that approach is effective or not. And it needs to be done, right? People who study organizational change and change of entire industries or institutions have some things to say about that.
Okay. I guess we are out of questions, so we can call it done a few minutes early before the end of the session. And then I think Miguel's going to join us and talk about what's in store for us tomorrow.
Well, thanks everybody. Thanks Matt, Tim, Catherine for joining this excellent session. Thanks Misha for doing a wonderful job moderating, generating questions, keeping everybody on time. For those of you who have joined us today, thanks very much for joining us. And a reminder that we will continue tomorrow at 9 a.m. AI, Radiology, and Decisions. We have another keynote speaker, 3 talks, more questions, and hopefully we'll have some answers. So thanks everybody. Have a wonderful Tuesday, and we'll see you tomorrow.
Thank you. Thank you to the speakers. And it was really nice meeting you. And I might be reaching out to some of you for potential collaborations. That's okay.